Good morning, everybody. Buenos dias. Welcome to the 8th annual ABRC conference hosted here at the Regional Center for Border Health, San Luis Walk-in Clinic. Can everybody hear me okay? No. Okay. Before we get started, I'd like to just let everybody know a few housekeeping rules. The restrooms are through this door. And if please, we'd ask everybody to please silence your cell phones or put them on vibrate. And before we go ahead and get started, I will let all of our speakers know that I will be sitting right here. And I have these minute cards. Two 2003.
relations, engagement, health and employee over the teaching center. I'm not pleased with that. I mean, recognize and tapping out on it. Where are you guys? Oh, back there. Been standing up there. So Kathy is, international liaison for bringing all of the university in contact with everybody for the research posters. And Kathy has not stopped. Every time we meet, she's going back into emails and Zoom meetings and making sure that engaging you all to be here today and make this event happen. So thank you, Kathy, for all the great work. Of course, a lot of the staff at Regional Center for Board Health, so the IT department, my staff, and Ray, my Santa, work together to put this. So there goes a lot into this. But I'm trying to show you that we care about this community, and you show that you care about this community in our quarter. And for that, we'll always be very appreciative. And so when we go through this program today, we have an amazing panel that you're going to hear all day. Think about the challenges that we can help each other to solve, whatever you are, whether you are in Mexicali, in San Luis, or Welton, or whatever you're coming from your community, from the rural perspective and the border perspective, how we can all collectively come with solutions to solve those challenges that you are facing, and that we are impacted by, no matter what we are. We're united by a border, not separated by the border. And so that is the most important message that I want to say today to my friends from Mexico. Thank you for being here. Your support, this event could not happen if you're not present here. We have a high number of very individuals representing universities from San Luis and Mexico. And so your knowledge, every time that I see your knowledge reflected in the research posters, and I encourage everyone to go and see them, it represents the commitment that you have to the families and their children in this border community, 4 states, whether it's Baja California, Sonora, and Arizona, to solve those very incredible challenges that we have every day. Regardless of the resources, regardless of the political environment, we're the ones that are going to solve those challenges. And so thank you again for being here today. And enjoy the event, ask a lot of questions, engage with your partners in your table, because this is what it's all about. And we have an amazing number of people sitting around you that will be all day long talking about and seeing and listening to panels that are going to talk about the different areas of workforce needs and research projects and all the things, amazing things that are happening in this county. So thank you again for attending this 8th annual event of Forum in Yuma County, and I will see you around here. Thank you.
And as you can see on your agendas, after lunch at 1 o'clock, Dr. Cruz Rivera, the president of Northern Arizona University, will be speaking. And on everybody's table, there are note cards and pens. And so if you want to start thinking of questions that you want to ask the president of the university, or if you want to wait till after his speech, but just know that those note cards are there for that reason. Next on our agenda, I'd like to introduce to you Dr. Michael Sabbath, Dean and CEO of NAU Yuma Campus. Mr. Michael Sabbath is the Dean for the Northern Arizona University and Campus Executive Officer for NAU's Yuma Branch Campus. He earned a Bachelor of Science in Business Administration from the Haas School of Business at the University of California, Berkeley, and a Master's in Public Administration from California State University, and a PhD from the Graduate School of Public and International Affairs at the University of Pittsburgh, Pennsylvania. Dr. Sabbath was with San Diego State University for 23 years, serving as a professor, division chair, and associate dean. Prior to this, he taught in the School of Business and Public Administration at the University of Missouri, Columbia, and at Indiana University, Bloomington. His research has focused on public policy and management issues related to the justice system and transnational cooperation. Please help me welcome Dr. Michael Sabbath.
Thank you, Alex. I'd also like to welcome you here today and thank you for being here today. As Amanda pointed out, is this working? It is good. As Amanda pointed out, your presence really represents a commitment to addressing some of the more pressing health inequities facing the people in our communities here in the border region. Um, it is our 8th annual ABRC forum, which I'm just shocked we've gotten to this point. I thought we'd have 1 or 2 forums and move on from there, maybe try a different format. But with the support from the state of Arizona and ABRC, we've been able to continue this activity now for 8 years. And I know that because I have to increase the font size on my notes. I can't read them as easily as I used to. I know some of you are going to find that's true as well. I see people here that were here at the first forum that we had all the way through the 8th forum. Many are friends and colleagues that we work with throughout the years. Most of them are better looking now than they were 8 years ago. I know they'll appreciate me for saying that. But it's another great opportunity to bring our colleagues together to focus on health inequities. Looking back over the years and the forums that we've had in the past, there are a couple things that always come to mind that I appreciate. One is the great spirit of collaboration. I don't think you'll find a more collaborative community and region anywhere, at least that I've experienced in California or other parts of the Southwest. This border region is truly a collaborative operation. Everyone gets along, we pull together, and I think that's why it's so successful. Amanda Gide and the Regional Center for Border Health have been tremendously successful in this region, and I'm convinced it's because of those kinds of connections and collaborations that we've been able to enjoy, whereas other communities have a sense of turf consciousness and conflict in some cases, and it's much more difficult to get things done and make use of resources. In any case, I do greatly appreciate the spirit of collaboration, but even more so, coming to these forums for me, it's the opportunity to network with colleagues and friends from other parts of the region, find out what they're doing and learn from them. And that's a lot of the focus of what we'll do here today. I really appreciate the fact that we have government agency representation, community organizations, universities, both public universities here in Arizona and colleges, as well as educational partners from Mexico, particularly our friends from UABC, Guadalupe Victoria, and Mexicali, UES, and also CETIS. It's a great addition to what we're trying to accomplish here and reflects really the pervasiveness of the problems we face that really cross jurisdictional boundaries. So, of course, the success of the forum really depends on all of you. Your participation, your ideas, and your commitment. And as always, it also depends on the support of a number of organizations, particularly the Arizona Department of Health Services, particularly the Arizona Biomedical Research Center that helps support financially this get-together, but also the Regional Center for Border Health and Northern Arizona University, particularly the Center for Health and Community Health and Engaged Research. I hope I got that right. I know we had a name change recently. So once again, good morning and welcome. And thank you for the work you do to advance health equity in our region. Thank you.
Thank you, Dr. Sabin. Our next speaker is Mr. John Garcia, Program Director for the Arizona Biomedical Research Center, Arizona Department of Health Services. Mr. Garcia, a second-generation Arizonan from Tucson, has dedicated over 40 years to public service, showcasing a diverse skill set across various roles within Arizona state and county government. Currently serving as the Program Director of the Arizona Biomedical Research Center, John's tenure with the Arizona Department of Health Services commenced 5 years ago. His career within public service has been multifaceted, encompassing positions such as policy analyst, research and budget manager, grant administrator, procurement and contract manager, financial controller, IT business analyst, project manager, and public safety dispatcher. John's academic credentials include an earned Master of Business Administration with a specialization in Information Technology Administration from Ashford University, now University of Arizona Global Campus, complemented by a bachelor's degree in management from the University of Phoenix. To further enhance his professional foundation, he obtained a certification as a public manager through Arizona State University's esteemed Advanced Public Executive Program. At the helm of the ABRC, Mr. John Garcia oversees the allocation of grant funds to biomedical researchers and Arizona universities, facilitating education initiatives for faculty, staff, students, and the public. Additionally, he adeptly manages the Arizona Public Cord Blood Program, contributing significantly to advancing biomedical research and healthcare initiatives within the state. Please help me welcome Mr. John Garcia.
Good morning. Thank you all for coming here. This is, I think, the second or third time that I've made it here. And I know that the ABRC has been funding this particular program, I think, from just about the beginning. And we're very pleased to do that because we recognize the unique situation that this particular community has in the health services area. There's so many different challenges here. As we know, the population is very fluid, and the needs run the entire gamut of health services. So, what you do is extremely important, and I'm happy that we're able to be a part of this. Let's see if I can manage the slides here. Okay, so the Arizona Biomedical Research Center was established in 1984. It was a standalone commission, and it grew very quickly, developed two different funding sources. We are able to give out research grants through tobacco tax, which is good. Unfortunately, we're doing a very good job of reducing the prevalence of the use of tobacco. So that means that our funding sources are starting to dry up a little bit. But you know what? That's okay. And then the other is funding for our research education program, and the cord blood program come from our lottery funds. So please go out there and get those scratchers and Powerball tickets, so that we can continue to put on programs like this. We were established to identify and support innovative biomedical research to improve the health of all Arizonans. And we're very happy to do that. Every year, we receive about 300 letters of intent for research projects from all across the state. And from the 300, we select about 200 to actually submit full applications. And that gets whittled down through the process to about 30 applications that are awarded. We give out about $5 million new money every year for these projects, and they run just about everything that affects Arizonans. Of course, we have like valley fever, diseases like dementia, Alzheimer's, ALS, diabetes, uh, every disease that you can imagine, we have a research project on. A lot of them are very successful. They end up translating into treatments and solutions that will help everybody. So our mission is to identify and support innovative biomedical research. I told you about our funding sources. We also receive special funding for different projects that are of importance to the people of Arizona. Recently, we were given $5 million to give out grants for marijuana testing to determine its safety and efficacy as that goes forward, not only as a medical treatment, but also as a recreational opportunity. And then $250,000 to research marijuana and its impact and interactions with other substances. And recently, $5 million was given to us to seek psilocybin clinical trials. This is a possible solution for diseases like PTSD, chronic pain, etc. So, and now we're working on just about ready to give out a grant award for research on ibogaine, which is another natural psychoactive substance that can also be used to treat diseases like PTSD and other chronic diseases. Just our website, adhs.gov/biomedical, and you can find more information about all our programs. We have an annual report that you can find on that website under documents, and that gives you an idea of what we do every year. Our staff, we have our executive director, Dr. Victor Waddell, my deputy program director, Keelan McCool, Teresa Caro, Mary Carson are our grant administrators. We have a finance manager and a senior procurement specialist. We have three major program areas: public cord blood program, research grants, and research education. Our research education is divided with the three universities, ASU, U of A, NAU. And the cord blood program, we have donation sites at Tucson Medical Center, Dignity Health, St. Joseph's in Chandler, and Valleywise in Phoenix. And that's my rundown on the ABRC. But again, I want to thank Amanda and all the team that has put this program together. All you elected officials out there who are very supportive of this endeavor, and all of you for the parts that you play in bringing the best possible health care to this community. Thank you very much.
Next, we have the Workforce Development and Rural Communities panel, and the first speaker will be Mr. Jerry Cabrera, President and CEO of Elevate Southwest Border Health Internships. Mr. Jerry Cabrera is the President and CEO of Elevate Southwest, where he leads cross-sector strategies that connect education, workforce development, innovation, entrepreneurship, and regional economic growth across the greater Yuma region. With executive experience spanning nonprofit leadership, public administration, healthcare-connected initiatives, and community partnership building, he has helped advance efforts that strengthen talent pipelines, expand innovation capacity, and position border communities for long-term competitiveness. Mr. Cabrera brings a strong healthcare lens to his work, with experience supporting community-centered efforts that intersect with public health, healthcare access, workforce readiness, and regional quality of life. His leadership emphasizes the importance of aligning healthcare education, industry, startups, and applied research so that communities can build stronger systems of opportunity and better outcomes for residents. A key part of his work involves cultivating startup and entrepreneurial activity in the region by creating spaces, partnerships, and innovation-focused conversations that encourage new business formation, technology adoption, and industry collaboration. Through Elevate Southwest, he has championed initiatives that support emerging entrepreneurs, strengthen the innovation ecosystem, and connect local talent and ideas to broader opportunities in Arizona's evolving economy. At the Flynn Foundation's Bioscience discussions, Mr. Cabrera contributed to a border region perspective on the future of biosciences in Arizona, highlighting the importance of connecting healthcare workforce, innovation startups, and regional collaboration so communities outside major metro areas can participate more fully in the state's bioscience economy. His work continues to focus on building practical partnerships that translate vision into community impact. Through Elevate Southwest, Mr. Cabrera champions collaborative models that bring together public, private, academic, healthcare, and community partnerships that create pathways for student success, talent development, startup growth, industry advancement, and regional resilience. Please help me welcome Mr. Jerry Cabrera.
Thank you very much. I am a lumberjack. Didn't say it on there, but yeah, I am a lumberjack. Thank you, everyone. Thank you for coming this morning. I greatly appreciate it, and thank you, Amanda, for the opportunity to speak on our great need of collaboration. I've spoken in aerospace, spoken to UABC, CETIS across the border, and US as well. So it's been a great pleasure of coming here and speaking with you as well. It's certainly a great road that Elevate Southwest has taken from its incentive. The original mindset was totally different what it is now, which I'm glad it has been. And it's been kind of a great pleasure because of the guidance that many of you have given us of where to go. And that roadmap has certainly led us to where we're at now. Let's see how this thing goes. Okay. One thing that we do have is we do have 4 pillars. I'm not going to go through the whole slides because there's about 15, 16 slides, and I'm not going to go through all of them. There's probably 2 or 3 slides that actually do affect us great deally. We do have a lot of startups, workforce, and community, obviously the innovation and startups. And one thing that we have noticed on our demographics is the amount of baccalaureate attainment that we have here in the region. And that's the reason why Elevate Southwest had started. You know, we're at 16.7, and ABRC actually, when they came down to visit us, kind of mentioned greatly deal with that in terms of what we're trying to accomplish. Obviously, from AWC and all 3 universities, we try to make that effort and move that pendulum to one side. But one thing that we've noticed as well is giving the experiential learning to our students, especially on the healthcare field. It's quite impressive how many students want to go into the healthcare field, even at the high school level and some of the college level. The only thing that we've noticed is that the doors are not open. Some of the doors for some of these organizations, now I'm not saying all of them, obviously, they can't open doors for whatever policy and or liability issues. And for the ones that have opened the doors, it has made a tremendous effort of these kids. Now they want to be nurses, doctors, and researchers, as a matter of fact. So that has made a huge, tremendous effort on where the students are leading themselves for the future of our region. Remember, our region is not the 200,000 people that we have here. Our region is 1.7 million. When you take into account San Luis, Mexicali, and Imperial Valley, that's a huge amount of opportunities for us to take part of and make sure that there's a difference on the healthcare of our community, but not only importantly, on the experiential learning of our students. I forget about this. I can't see it here because there's a. one aspect is I kept on discovering as I went to speak at different organizations on the aerospace and the Flint Foundation and all these other universities. One thing comes to mind, and it was a human factor of everything that we have kind of accomplished and have discussed. We have discussed economic development, we have discussed experiential learning, we have discussed a whole slew of areas. And one thing that has taught me is trust. When we go to interviews and we go to all these type of different areas within our own ecosystem, and I say ecosystem because of the region. One thing that has led us to move forward is trust amongst ourselves, amongst our border communities. And if we don't continue that effort, that's what breaks us down into bogs us down into moving forward. And in the last couple of meetings I had actually with Dr. Sabbath, he has actually taught me a lot of things here. He probably doesn't even know. It was trust, because he gave me that trust from the very beginning. He opened those doors for me to actually help and speak in other avenues, because not everyone trusted Elevate Southwest and what we were trying to accomplish. But he saw what we were putting together for our internship program, for our startups, or even for professors at NAU at the college level and other universities. So that's one thing that kind of helped us move forward, and one thing that keeps us evolved and make us grow as a community is that trust among people. Yes, we obviously have to do our due diligence before we do a lot of things, but that trust on our neighbors, within our own family, will help us grow and make sure that our students are moving forward. Yes, it takes talent. Our healthcare workers and entrepreneurship programs, that's what's vital for us to move forward. But again, I go back to the human factor of where we're at, where we're going, and the future of our region. And it just takes one conversation that lead us to where we're at now. I'm not going to go to everything because there's a lot of slides in here, but I want to thank you for giving me the opportunity to speak to you about our experiential learning programs and internships that we have at Elevate Southwest. We give opportunities for not only the healthcare, but engineers and other avenues of a career opportunities. So thank you very much.
And we'll leave some time for questions and answers from the panel afterwards. Our next speaker is Dr. Janina Johnson, who currently serves as the Distinguished Dean, Maria and Steve Sanghi College of Nursing at Northern Arizona University. Dr. Johnson has served in a variety of clinical, academic, and leadership positions. Her clinical practice background includes caring for patients of all ages within community and hospital-based settings. In the academic setting, Dr. Johnson has served in faculty and academic leadership roles. She has led and directed traditional and accelerated campus-based pre-licensure nursing programs and online RN BSN graduate programs. Dr. Johnson is an experienced speaker, both nationally and abroad, presenting on a variety of topics, including clinical supervision, program evaluation, trauma-informed care, self-care, and different models of care and service. In addition to her role as Dean of the NAU College of Nursing, Dr. Johnson also serves as an external consultant for nursing programs. She is a certified nurse educator through the National League of Nursing, served as an elected member of the National League of Nursing, CNEA Board of Commissioners, and currently is on the Board of Directors for Northern Arizona Healthcare. Dr. Johnson holds a Doctor of Nursing Practice and Education Leadership from American Sentinel University, a Master of Science in Nursing from Nursing Education from Walden University, and a Bachelor of Science degree in Nursing from the University of North Florida. Please help me welcome Dr. Janina Johnson.
Good morning. Thank you for this opportunity to come and speak here and share a little bit about nursing. So I am all about nursing, and so you'll hear this here and some of the innovative things that we're doing at Northern Arizona University. Got it. Okay. So this is, we were just newly named the Maria and Steve Sanghi College of Nursing, which we're very proud of, and this investment in what we are doing to help expand and increase access to nursing. And so I wanted to just to share our vision and mission, vision, and strategic directions and get us to where, how we came up with creating our global BSN program that I'll talk about. And so our mission is to elevate nursing through innovative education, scholarship, and practice to advance health, promote well-being, and strengthen communities. This aligns with NAU's overall mission as well. Our vision is to be the recognized leader in bold, purpose-driven nursing education in Arizona and beyond, with a focus on advancing health in underserved, rural, and indigenous communities. And our strategic directions that really guide how we get here and how we develop our programs and the things that we want to do and the efforts that we put into those are elevating excellence, expanding access, and engaging in well-being. So in bolded, expanding access, because that's what we're really focused on right now. And so there is a nursing workforce shortage here in Arizona, and Arizona is one of the largest, is one of the states in the nation with the largest nursing shortage. And there's about predicted 28,000 to 30,000 nurses that we need now today. And so this shortage is disproportionately felt in rural communities. There's high vacancy rates around Arizona, but more in rural and tribal healthcare facilities. And there are issues with recruitment and retaining nurses in those areas. And so we've seen in nursing shortages before. It's kind of a cyclic pattern. Every 10, 15 years, there's a shortage of nursing. And we put into place some strategies that I think are short-term to address the immediate need that we're seeing, but fail to create long-term strategies to address those shortages on a long-term basis. And so some of the short-term things we've done before is hiring travel nurses. I think probably a lot of you heard about travel nurses, especially during the pandemic, and leaning heavily into the travel nurses, which costs a lot for our healthcare systems and also can equate to some lower patient outcomes as well. And then also supplementing with licensed practical nurses and unlicensed healthcare workers, which are great in our healthcare systems, but is also very important to have bachelor's prepared nurses that are working in our healthcare systems. And so I will do a little plug for bachelor's prepared nurses. In nursing, you can become a registered nurse through an associate degree, and then also through a bachelor's degree. And there is evidence over the last 2 decades that has consistently demonstrated that higher proportions of baccalaureate prepared registered nurses in the hospital workforce is linked to a significantly improved patient outcomes and organizational efficiency. So it's really important for us to provide more bachelor's prepared nurses out there serving our communities. There are some drivers to the shortage, and these are for for our nursing shortage, some of the things that are happening now that are contributing to this current shortage. One is our aging population. And so people are living longer, which is amazing and awesome, but they're also living longer with comorbidities, chronic issues, illnesses that need care for that. And also our current aging population happens to be the baby boomer generation, which is a very large population. And so in Arizona, we also have a higher number of aging adults as well. We also have an aging workforce in nursing. And so the average age of a nurse right now is 55 or older, depending on the area that you're looking at. And it's expected that nationwide, over 1 million nurses will retire by 2030. So we can't keep up with that demand. And also in nursing, we do hear a bit about burnout or emotional distress that has happened, especially was amplified during the pandemic, but is something that has always existed in nursing. And then we have those higher patient acuities. So patients are living longer and they're sicker, right? And so dealing with those has led to some nurses leaving our profession. And then another factor too is while there continues to be a great demand for enrollment in nursing programs, nursing program growth is restricted, primarily due to the lack of clinical placements that we have for our students' experiences, qualified faculty, and physical infrastructure that or space that will prevent the preparation of new nurses in our programs. And so this is expanding fast enough. We're not expanding fast enough to meet the needs of addressing that shortage that we're currently experiencing. However, this is good. Good news is that NAU is positioned to positively impact the nursing workforce shortage, and we've already made great progress. So as I said, one of our strategic directions is expanding access. And so how we're doing that is in multiple ways. We've had an existing infrastructure of partnerships and program pathways that prepare our nurses to excel and practice in rural and community areas. So that's been our history already, focusing on those areas. In the last 3 years, I've been at NAU for about 3.5 years now. And in the last 3 years, we have tripled our enrollment in our baccalaureate BSN entry to practice program. And that's for those who are wanting to become new registered nurses. And we have dedicated seats in there for our Native American students and veteran students now as well. We've received over $7 million in funding, primarily that went to scholarships to prepare almost 300 new registered nurses from summer of 2023 to date. And these nurses are committed to working here in Arizona. Over 80% of our graduates stay and work in Arizona. And we expanded our nurse practitioner programs. We have traditionally had a family nurse practitioner program, and now we've added a psychiatric mental health nurse practitioner program as well. And then we recently launched our new pathway in our BSN program, which is the Global BSN. And this is really specifically aimed at addressing our nursing shortage in rural and underserved communities. So some of the things that are creating barriers for us having nurses in rural areas and addressing that shortage there include things like limited mentorship. There are less nurses that are working in the rural areas that can provide mentorship to new nurses. Resource constraints. And so there might not be the equipment that is needed or compensation to bring nurses into rural areas. And then also there are some amenity gaps. And so maybe there isn't the hair salon there or restaurants that someone's seeking that might be used to if they're used to living in a city and then going out to a rural area and not having those amenities. And cultural isolation too. It's an adjustment. And so these are some of those barriers. Some strategies around those barriers include pipeline development. And how do you develop a pipeline of nurses for those rural areas? Local clinical placements. So having those students come into those local areas and do their clinical experiences where they're doing hands-on care for patients. Immersive rotations. So creating experiences where they are immersed in a healthcare system in that community. And then also transition to practice programs. And so extending time for new nurses to transition from education into practice in that healthcare setting in the rural area. And I'll come back to that slide. So when I was thinking about all these things and how do we increase access, expand access, one of our strategic directions into rural areas, came up with this concept of the Global BSN nursing pathway. And so this is preparing new nurses, but it's focused on building nurses in communities for communities. And it's really looking at this ecosystem of how we create our nurses with the community at the base of that ecosystem. And so it starts with exposure for our students. In the community. So we want to expose and our students to, or future students to, one, college education, which is important, and then two, primarily our nursing profession. So we started that out with looking at doing some nurse exploration camps, which are aimed right now, targeted towards high school students in the communities that we have partnered with. And it gives them exposure to our nursing profession, to college, to local community colleges that they can build upon. And then the next step, if you can see, I'm kind of going clockwise on the on the diagram there. The next step is pre-nursing. And so how do students prepare for nursing programs? And so you can do that direct entry, go to NAU. You'd have to relocate from your community to go there, take your pre-nursing prerequisite courses, or you can stay in your community and do that through a community college. And so you'll get those prerequisite pre-nursing there. And then you apply to our nursing program, and this is focused here on our global nursing program. We do have a little off-ramp there. If you didn't get into the global nursing program, we still think it's important to support those students in other opportunities for careers or education to advance. And so we have a process where we reach out to those students and provide them with those extra opportunities that they can have. And then once they get into the global BSN program, they can complete their degree primarily in their location, in their community, without having to relocate to go to college at that time, graduate. And then our hope is that they stay in their communities and work there in the community. And so this was the idea we had around the global BSN program. I call the pathway the optimal blend between in-person and online learning. We do have online courses for those students so that they can stay within their community and learn. And these are scheduled classes where they have their Zoom sessions with their faculty and their classmates as well. And then they have some experiences when they come to a location nearest them. At NAU, we have locations in Phoenix, Yuma, Tucson, and Flagstaff. So they'll come there, do some of their hands-on skills, and then they do all of their clinical experiences and community outreach within the community for which they live and are going to continue to work and serve. We started this in fall of 2025, and our first partners are in Parker with La Paz Regional Hospital, Lake Havasu with their regional medical center, Cottonwood in Valley Verde as well, and coming soon will be Summit Healthcare in Sholo. So again, we're really trying to prepare nurses in the communities for the communities in which they live. So this here is a picture of one of our first nurse exploration camps that we had. And this is with the high schoolers that came to learn about nursing and college. And the importance of these camps to me is really the early exposure to college and to our nursing professions. You probably can't read from there, but one of my favorite comments on here from a student was, "Thank you for helping me have a bigger pathway for my future that I never thought I could see myself in." It's important, I think exposure and experience help expand possibilities in the minds of our youth. So it's important for us to provide those opportunities. And then also we have our global BSN practice observations in the community. It's community outreach, community fairs that they're doing. They're embedded in their communities. And then also their clinical immersions at that local health care. We know that students go where they're comfortable, and for many students, that's staying local. I'm going to amplify a statement by Mr. Jerry Cabrera, thank you, that you had in your other slide about what my experience has taught me. And it was that talent stays when opportunity is visible. If you can see a credible future in your own community, you will stay. And I was like, oh my gosh, this is exactly what we're trying to do. So thank you. This is what we're hoping will happen. And we've had great student feedback about this. And we do also understand one of the strategies for addressing that gap between rural workforce, it was immersive rotations and local clinical placements. And so some of our students, as we started and launched this program, it would be difficult for us based on a short recruiting period, for us to get all of our students local in the communities that we've partnered with. But we do have, and in our application process, it was people who thought that I want to relocate there. And so they now are having these immersive opportunities in those communities, and they're excited about staying there. And here is one of our first classes, our cohorts of the students who are at the La Paz regional medical center. And they just felt like very connected to the community there, which was really awesome. Within that healthcare system as well, they offer students housing. So in their final semester, they could do an externship working there, and then they transition straight into the transition to practice, another one of those strategies, residency program there. And they have some little tiny houses that those students can stay in if they are not local. And then the students do commit to stay to work there 2 years. And of this group, they are all super excited for that opportunity. I think we do have one local student in there as well. And this is a video, I'm not sure if it's going to play or not.
Ever since I was 5, the idea of being a nurse never changed. That's the only dream.
Exactly why we're doing what we're doing with our global BSN program. Do I have control again? Okay, thank you. I'm actually going to go back to the slide I skipped. I think I'm going back. So we started with that global BSN concept, and then realized this really is a greater concept, what can be situated within this greater concept of this rural focused nursing education and healthcare ecosystem. This is really part of the ecosystem. Very busy slide. I'll try to walk us through it. I haven't got a minute flash yet. I feel like I take a lot of time. I talk a lot. I'm okay on time. Okay, great. So at the bottom of the box, if you can see there, it's community engagement. And put that here on this slide or this infographic to really emphasize the importance of community. We start in the community, we prepare in the community, and we're committed, and they continue on in the community once they've completed their education. And so this really identifies those areas in the ecosystem, which are critical points for helping create students who are prepared to go back and practice in their communities. And so the first one in the yellow is our early exposure. So we did launch our nurse exploration camps, which were aimed at high schoolers, but we do realize that's a little late, right? Early exposure needs to happen earlier. And so we actually want to focus on pre-K through 12th grade community outreach. We went to a middle school, met with students in their AVID class, and talked about the nursing profession, left a really big impression on some of those students, which was really great. But multiple opportunities for us to be in the communities with our youth, and so that they get used to like, oh, NAU, oh, like I can go to college, and then, oh, those are nurses. So opportunities around there, partnering with our area health education centers with AHEC, who can help us to provide these outreach experiences. And then also later on, as we move through our ecosystem, there's also support for students around travel stipends and scholarships and other things that students might need as they move forward. So as they continue on their journey, they get to the little blue area there, and that's our exploration camps, which I had talked about. And then they continue on, and we have opportunity to partner with career and technical education as well, that might be providing students with some preparatory skills, such as nursing assistant skills or medical assistant, which they can build upon then in nursing education. You can go from there, from high school, and fast track straight to NAU if you'd like, or you can take the community college route, which is the top route in the blue, which helps people stay local for their prerequisites and their pre-professional degrees. And then in the green is where the NAU programs are. And for this, that is our global BSN program. That's where we engage with the students there, preparing our students in communities for their communities. Upon graduation, they have opportunity then to move on for post-graduation, which is our final blue there, trainings that we can do collaboratively in the communities as well to provide advanced education or advanced training for people who are already now skilled as nurses. And then the yellow, if I move back one little, I don't know what that is, one little circle point in the yellow is really our healthcare systems. And it's really important for us to partner with our healthcare systems in the beginning. And we provide opportunities where we can support our healthcare systems and they support us as well. And so after we also can do joint appointments with them. So we have nurses that are actually helping precept our students in those areas. So there's a acculturalization for those students as well. And so that's an important part too. And so we really look at this as how we really embed ourselves in our communities and prepare our nurses for those communities and are addressing the nursing workforce shortage one student at a time. And I have my last here slide. Sorry, as I flip through everything very quickly. Is this. I wanted to talk about our nursing practitioner program just for a moment, because when we're talking about nursing shortage, there's also a great shortage of primary care needs and mental health needs, and again, disproportionately felt in our rural communities. I did have a few statistics on this. In Arizona, only 39% of Arizona's primary care needs are being met. And by 2032, it's predicted with current population growth, Arizona will be short 412 nurse practitioners. All 15 counties in Arizona are now classified as partial or full health professional shortage areas, which is a federal designation for areas, populations, or facilities lacking sufficient primary care, dental, and mental health providers. While we see growth in urban areas such as Tucson and Phoenix, and they're struggling to keep pace with that rapid growth of producing nurse practitioners, the burden is disproportionately felt in our rural areas. And in some rural counties, the patient to provider ratio exceeds 3,500 patients to one provider. And in some of the articles that I read, it was actually up to 5,000 to one. And that's patients to providers. So this is making consistent preventative care almost impossible without having those nurse practitioners in those communities. And the shortage is even more acute in behavioral health. Recent reports show that only 10% of Arizona's mental health providers' needs are being met. So this is another area that we're working on, helping to address that shortage as well with our nurse practitioner programs. So we do have rural primary care placements. We have collaboration with community health centers and medically underserved areas as well. And since 2007, we have participated with the University of Arizona in the Arizona AHEC Rural Health Professions Program, which is actually taking students into immersive experiences in those rural communities. And we've had great success with that, having students who then graduate and do work in those communities as well. So as we continue on in our future focus and how we're growing, there's more ample opportunity for us to partner with our AHEC partners for us to, again, increase that early exposure in the communities for those potential future students or at least college graduates. There's also ample opportunities for us to partner with our practice partners, with other healthcare systems and centers where we can provide collaborative scholarships, address tuition and fees, which can also be barriers to education, with offering 2-year work commitments. First-year retention, really rough in nursing. If we can get nurses past the second year, then the retention rates skyrocket from there. So a 2-year work commitment would be very important in that. And then also other opportunities with preceptor grants, joint appointments, as I had mentioned earlier in my presentation. One of our barriers is lack of qualified faculty. And so that can help with the qualified faculty as well. So these are just some of the ways that we continue to focus on strengthening our partnerships to prepare more nurses with the intent to support recruitment and retention at local community healthcare centers and ultimately address the nursing healthcare shortages that we are so greatly feeling at this time. Thank you. Thank you.
Thank you, Dr. Johnson. We're doing really good on time, so I haven't had to use my little flashcards yet. And next on our agenda is a very good friend of the Regional Center for Border Health, a longtime friend of the Regional Center for Border Health, Dr. Kevin Dreesen, who currently serves as Teaching Health Center Director for the Regional Center for Border Health, where he is helping to develop a family medicine residency, program and supports RCBH's program planning and development. Before joining RCBH, Dr. Dreesen held positions as director of the Arizona Rural Hospitality Flexibility Program and assistant professor at the Melanina Zuckerman College of Public Health. While at the University of Arizona, he helped plan and develop the Arizona Area Health Education Center, AZ-AHEC system. After leaving the university, he served as Southern Arizona Administrator for the Arizona Healthcare Cost Containment System, ACCESS. Dr. Dreesen is founding director of the Arizona-Mexico Border Health Foundation and has served in a volunteer capacity as president for the Arizona Rural Health Association and the Partners of the Americas, Arizona Oaxaca chapter. His professional career began in the Peace Corps and then continued as a consultant for the U.S. Agency for International Development, conducting health profession training programs for USAID Mexico, Colombia, Honduras, Peru, and Bolivia. He received his doctoral degree from the Department of Psychology, University of Arizona, and a master's degree in public health with a specialty in health education from the University of California, Berkeley. Most importantly, Kevin is a proud father of 3 children. Will you all please help me welcome Dr. Kevin Dreesen?
Well, good morning, everybody. Buenos dias a todos. I'm very happy to be here to talk a little bit about the challenges and opportunities in medical education. And what an excellent segue to begin by talking about the nursing shortages. There's a lot of similarities. There's also quite a few differences between the preparation of nurses and physicians. But the whole discussion of pathways is what I'll be talking a little bit about. And I'll be offering a description of some research we've conducted that essentially tested some questions around the existence of a clinical pathway. So I won't go deep into this. There's a shortage of primary care providers, healthcare professionals, as was previously explained in terms of nursing. Arizona has about currently satisfies about 40% roughly of our primary care physician needs. And we're expecting a shortage within the next 4 years of between 1,900 and 2,000 primary care physicians. These affect the shortages. It's a public health issue. It affects our public health, but it also it's a health services issue because it makes it more difficult to operate healthcare services in rural communities, more difficult, more challenging, but also it's more expensive. They have to pay more. They have lower volumes of patients. It's more expensive, harder to operate healthcare services in rural communities. Currently, as is stated on the slide, Yuma County has about a shortage of 12 FTE primary care physicians, and Mojave County 15 primary care physicians. The trend, as you can see on the graph, shows the blue line is Yuma County at the top. You see a general decline in the shortage, which means an improvement. But it also demonstrates a disparity between the urban counties. The green line there is Pima County at the bottom, and then the red line and black line are the Maricopa County, and then the state averages. So you can see over a 10-year period of time, there's been a decline with a little bump there, a decline in the shortage of primary care physicians with the little bump during the COVID years. And Yuma County compared to the other rural counties is right about in the middle. You can see in the gray box with a black line around it, we are in the middle, but other counties, Apache County and Pinal County, up to the north and to the west and to the east of us, have a much higher degree of shortage, whereas the urban counties, Maricopa and Pima County, have are the green bars there, and they have a less degree of shortage. Now, why does this matter? Well, at some point in everybody's life, you're going to need to see a healthcare provider, be it a physician or advanced nurse practitioner, somebody with that level of clinical expertise. And especially if you have some kind of special condition, you're in an accident, you give birth, you need primary care, specialty care, emergency care. It's a public health need. And elder populations have a greater degree of healthcare services. And again, physician shortages, healthcare shortages, I don't mean to just focus on physicians, but that's what I'm talking about. Healthcare workforce shortages are a critical public health issue. So why does it matter today? That's why it matters. Why does it matter today? Well, there are three things. Timing, as we all know, is really important in the process of change. And there are three initiatives that are currently evolving that could really impact the the physician shortages. First of all is the University of Arizona's Phoenix campus is currently developing a 3-year curriculum. They're going to fast track their training of physicians, which is usually a 4-year process. They're going to cut it down to 3 years with the intention of trying to get physicians faster into the workforce. That's that first bullet. The second bullet is something that people from Yuma are very well aware of at this point, is the University of Arizona's Phoenix campus of the College of Medicine is establishing a medical school branch here at Anvita Health in Yuma that's going to train up to 15 medical students per year for the last part of their clinical training, the last 18 months. And that could have a really big impact on the physicians staying here once they graduate in Yuma. And then finally, and very quickly, I'm going to just mention that the Arizona governor has been approved to release, to begin the Rural Health Transformation Program, which is a very large program, $167 million per year for a 5-year period, is going to be invested, much of that in healthcare workforce. And we're waiting, even as we are now in April, we're waiting May, June, July, we're waiting for those funds to be released. And a large portion of that money will be dedicated to workforce development issues, healthcare workforce development issues. That's the good news. The challenge is what the federal government, the Centers for Medicare and Medicaid Services, is doing is they're taking money away from the eligibility for Medicaid, from coverage for low-income people. They're taking money out of that side of their program, and they're dedicating it to this Rural Health Transformation Grant. So they're actually creating, on the one hand, a set of very difficult circumstances, especially for rural healthcare providers, because Medicaid is so important in rural communities. They're going to lessen the Medicaid population in rural communities. And that's going to create really difficult operating environment for rural healthcare services. So we conducted some research to try to understand better the physician workforce shortages. And we got some data, which I'm going to explain in a minute, but we conducted some research with two primary questions. And that is, we were very interested in learning about the relationship between a physician's medical school, where did they graduate from medical school, and their location of practice was one of the questions that we had. And the other is the bigger question is we wanted to look at this idea of there being a healthcare of a workforce pathway, and how is that actually functioning currently? So those were the two research questions that we adopted, and we got a very exploratory design. We created an exploratory design just to look at the relationship between two variables. And again, the two variables are, where did the physician graduate from medical school, and where are they currently practicing among those that are currently practicing in Yuma County? We got 10 years actually of data from the Arizona Medical Board, and that's data only for allopathic physicians that are MDs. That doesn't include any data for the osteopathic physicians, the DOs, of which there are that practice here in Yuma County. It's only for MD allopathic physicians. And we created the hypothesis essentially that there is a pathway between where the physician graduated from medical school and whether they're practicing here in Yuma County, or where their practice location is. I'm going to skip that because it gets pretty complicated. This is our rendition of a health career pathway. Dr. Johnson's was much more creative, much more interesting looking. But there's several important things to look at here. Research has shown that little kids in middle school begin thinking about what they're going to do as they get older. I want to be an astronaut. I want to be a nurse. I want to be a doctor. I want to be a teacher. I want to work on the farm like my parents did. I want to lay bricks like my uncle does. So they begin in middle school. And so the idea of developing this pathway is to get started by encouraging kids in middle school, telling them about the different potential of medical careers, healthcare careers, starting in middle school and then going through high school, trying to track the kids through their educational career into college, and that can be community college, university as well. But you're supporting the kids, you're telling them what kind of coursework they're going to need, what kind of, how to all about financial aid, other conditions. You're supporting kids at the beginning. But then I think what happens is there's a competitive process that begins to accrue. And it was mentioned earlier, the doors seem to close. And that happens once medical education starts. The doors begin to close for kids. So those that want to become physicians, roughly for the University of Arizona, they accept 2% of all the applications that they receive for medical school. There's a slide later on for all of our medical schools, and there are 7 in the state of Arizona. The highest percentage of acceptance rates are maybe 5 or 6% of all the applicants that they get. So getting into medical school, the doors close, and then conducting their, getting graduate medical education, getting their residency programs, doors begin to close with that as well. And so by the time you get to the end for medical practice, it's becomes very uncertain in terms of where physicians will end up practicing. I mentioned about the data we got that we received from the Arizona Medical Board. For 1 year, 2025, there were more than 16,300 licensed medical doctors in the state of Arizona. In Yuma County, there were 366 that were identified. And those are individuals that have medical licenses, current medical licenses. Those are not individuals that may be actually practicing. We don't know if they're actually practicing. We don't know if they are, how many hours they're practicing. So all we know is, do they have a medical license, and are they in Yuma County? The other thing, though, that we do know is from where did they graduate medical school? So that was the data that we worked with. This is essentially our version of what we tried to test, is the relationship between where did the licensed physician graduate from medical school, and are they practicing, or are they, for those physicians that are currently in Yuma. So just the 2 yellow boxes, that's what what I'm talking about now is involved, just those 2 yellow boxes. Now, we recognize that a person's life experience is incredibly influential. If you're more likely, if you come in from having rural life conditions when you're younger, Or also the idea of where you complete your residency is an incredibly influential factor of where you actually end up practicing. We have no information, at least in this data set, we have no information about those two conditions. Although at the end, I'm going to give a little bit of insight that we've developed around residency programs. So this is the results of what we found. Of the 366 I mentioned, there are 366 medically licensed individuals currently located in Yuma County. And of those, 55% of them graduated from a medical school outside the United States of America or outside of Canada. Those are international medical graduates. Roughly 45% are U.S. medical graduates. And that was surprising to me as we spoke about it within our team. It's not surprising to the other people that actually run the healthcare services. In fact, if you look around the state, there are a lot of the physicians, if it weren't for international medical graduates, we'd be in much greater trouble. That if you think about that line I showed early on that we're sort of going down, without the international medical graduates, we'd be at a much more severe level of a shortage. Where are those international medical graduates from? Well, we looked at the data again, and 49 of the 202 medical physicians, MDs, were graduated from a university in the Caribbean, and there are 5 or 6 different universities there. 43 of those physicians, or about 12%, graduated from a medical school in India. Philippines, 17 students. And I wanted to highlight Mexico. 10 of the individuals who are licensed MDs in Yuma County graduated from a university in Mexico, which I found quite interesting. I'll talk a little bit later. But if you look at the range of different countries, it's 20 or so different countries where our international medical graduates are coming from. Actually, more like 40. A wide range of locations where they're arriving from. So that's the international medical graduates. The U.S. medical graduates here, 20 of the 366 graduated from a university here in Arizona, in-state university. Most of them were UA Arizona, although there are 7 medical schools here, but most of the individuals here were from UA Arizona, which is about 5.5–6% of the total cohort were trained here within the state. And you can look, just as many doctors were trained in California as in Arizona. Again, a great dispersion of where the domestic medical graduates were from. They're arriving, in short, our medical doctors that are licensed here in Yuma County, they're coming from all over the place, all over the world. There's no really specific source according to this data at least. And so what that allows us, we didn't conduct any complex statistical analysis. You look at the data, and it appears that our hypothesis can be rejected, that there is no direct pipeline in terms of medical education and practicing here in Yuma County. And that's the basic fundamental message we have. The other is that the UA Arizona is that second bullet there. They're graduates. They're an important cohort, especially for our preceptors and clinicians. The arrangements, they're a really important cohort for practice of medicine here in Yuma County. But in terms of just absolute numbers, it's a relatively small number. You're twice as likely to have graduated from University of India as you are as having graduated from the University of Arizona. With that, we found very interesting. And just then, the first bullet is, without international medical graduates, we'd be in deep doo-doo, essentially, here in Yuma County, but I think around the state, around the entire state. That was the conclusion. The recommendations we have included, with only about 2.5% of our physicians having graduated from a medical college in Mexico, it seems like, and there are several certified, ACGME certified medical schools. Guadalajara is the big one. Mexicali has a medical school. It seems like there's great opportunity to take advantage of that pool of medical doctors that could be recruited. It seems like more collaborative training relationships in medicine seem like a really good idea with our Mexican counterparts. The other bullet there, it says there's tremendous, I can't overemphasize, there's billions, and that's with the B, dollars going into workforce development at the national and at the state level. If you think about our medical schools and what their budgets are, residency programs are incredibly expensive to operate. There's lots of resources that are flowing in for the training of physicians. And I think we need to be better advocates in terms of making certain that we're getting a good return on these investments to our rural communities. And there is a series of legislation we could talk about in another talk of efforts to try to make that happen. But we just need to be better advocates to make sure that our state and federal investments are having the impact that we want to have. The final bullet there is just, it'd be great to have easier access to UA Arizona's recruitment, but also their placement information so that we can better understand, who's getting in and then as well as where people are being placed once they leave medical school. Now, I've got a couple slides here. Again, the limitations of the data where there's no information in terms of whether the physicians are actually practicing or not. There's no information about whether they're primary care physicians or specialists or what kind of physicians they are. And then also that we recognize there are a lot of factors that are more important actually than medical school to determining or influencing where physicians practice. Now, this is my last that I'm going to show. And that's that fourth bullet. I had the opportunity to go to University of Arizona's College of Medicine match day. And that's where the medical graduates, they're medical doctors, medical graduates find out where they're going to where they're accepted to do their graduate medical education. So again, to become a doctor, you have to get 4 years of undergraduate work. You have to go through 4 years of medical school. Then you have to get at least 3 years in family medicine of graduate clinical support, clinical preceptorship, that's called residency. So I had the opportunity a week or so ago to go to the University of Arizona's match day. And some of the medical doctors there had a list of where all the students were placed in terms of their residency. And so this is unofficial data. It wasn't released by the university. I offer that sort of caveat with this, but I was surprised that 43 of the 112, so there are 112 medical students that were matched. 43 of them, or 40% of our medical students, matched at a Banner Health, either in Phoenix or in Tucson. And I thought to myself, well, geez, if there is a pipeline, at least from undergraduate medical education to graduate medical education, if there is a pipeline, it's a university to Banner Health pipeline that exists. So those are the numbers, about 40% matched with a Banner Health facility, either in Phoenix or in Tucson. The other thing that I found of interest was that roughly half of the medical students that graduated left the state to do their residency programs. And so that creates questions about where they're going to end up practicing. So I think that's it. This is a pretty complicated slide, which is essentially saying, we talked about the shortages, the number of doctors that were short already. This slide is the capacity to, the state's capacity to train physicians in family medicine around the state of Arizona. And the numbers are such that if you go in and look at all these numbers, so what this is saying, the red universities or the red GME programs are primary care-based programs like our own. Our teaching health center is based in a primary care center. The black universities or GME programs are based in hospitals, and that's the traditional model of training physicians, is hospital-based training. But if you added all those up, and the way to understand those numbers, a 5 + 5 + 5 program is in family medicine. You go 3 years. And so that means in each year they'll have a complement of 5 residents, 15 in the total program. But it means that each year, 5 residents will be leaving that residency program and hopefully prepared to practice. But if you look at if you look at the numbers of the physicians that are graduating from their residency program, we're unable to satisfy the projected need that we have over the next couple of years. And so the whole system in 4 years, my guess would be, at least in medicine, in 4 years, we're going to be standing and still observing the fact that there's shortages. So that's my spiel. I'm going to stick to it. These are the acceptance rates. There are 7 universities in Arizona that have medical schools, or 7 medical school programs, and those are the acceptance rates. And you see that that door is closing, because even if you want to be a physician, you're well qualified, you have good MCAT scores, you're paid attention, and you have very high academic achievement, the likelihood of getting into these programs is still very minimal, which is probably why many of our medical graduates go to the Caribbean and other universities. But you can see on a year in Arizona, about 800 medical students get into school. There's about 800 per year. So that's our group. This is our team at the Regional Center for Border Health, our teaching health center. Dr. Abhinav Marcus is our program director of our residency program, and Wendy Figueroa is the program coordinator. We have a small residency program, but it's an exciting program. So that's it. Thank you.
Thank you again, Dr. Dreesen. Our next speaker, before we get to the Q&A session, is Ms. Nidia Herrera. Ms. Herrera is the Executive Director of Arizona at Work, Yuma County, bringing over 34 years of experience in workforce development. She is dedicated to fostering strong collaborations with business and community partners to create impactful and meaningful job opportunities for Yuma County residents. With extensive knowledge of the Workforce Innovation and Opportunity Act and a deep understanding of workforce strategies, Ms. Herrera plays a key role in driving the continued success of Arizona at Work, Yuma County. Her leadership and commitment to economic growth make her a valuable advocate for both employers and job seekers. Please help me welcome Ms. Nidia Herrera.
Good morning. Thank you, everybody. Thank you, Ms. Amanda, for having me today. We had so many other speakers that talked before me, talking about the different pipelines that help our economy and help the growth within healthcare and in many more other industries. So I'm going to talk a little bit about Arizona at Work and the different pipeline and individuals that we serve that can also give them those opportunities to reach higher education. So let's see, let me get this going. Okay, so Arizona at Work, who we are. I'm going to put my glasses on. We are a federal funded Department of Labor program called the Workforce Innovation Opportunity Act. Arizona at Work serves the workforce development system within the state of Arizona. So within the state of Arizona, there are 12 local areas that represent Arizona at Work. So if an individual or employer is looking to access Arizona at Work, you'll find them in the different counties, such as Maricopa County, Santa Cruz County, and within these other different counties. So if someone is moving or having to locate an Arizona at Work, they can locate it by an Arizona at Work. The primary objective is connecting the job seekers with employment opportunities and deliver workforce services to both that individual and the employers that we serve. We are aimed to enhance workforce development by supporting businesses and building their skilled workforce. So Arizona at Work is operated by the Yuma Private Industry Council. Some of you guys recognize us from YPIC. And we've been operating since 1988. YPIC also operates a charter high school. We actually serve about 110 individuals, and we've been doing the charter high school since 1997. It says, why our work matters. We help improve the talent pipeline by connecting our individuals with employers and provide them skilled workforce. Employers do benefit from our skilled workers. We connect the job seeker to employment, training, or other resources that we might not be able to assist them with. Our young adults often are unsure of what career paths they want to take. So we help them with looking at those career pathways by giving them career exploration and some other resources. Hiring costs for we provide is to support and reduce employers' recruitment and training expenses. Okay, what population do we serve? We serve in our adult program 19 and over. Those that are unemployed or have been laid off, they could be disabled, justice involved, or even homeless. And there's a lot of other categories of barriers that they might have that we assist them to be able to give them those opportunities to either get education, training, short-term trainings, or employment. On our youth side of our programs, we serve 16 to 24. Again, those are individuals unemployed, dropped out of school, justice involved. They can be parenting youth and some other barriers that they might have that can qualify them. We do serve our veterans and military spouses, and we just look at what their individual needs are and skills, try to reskill them, try to explore education and certificate pathways. And there is qualification based on our programs that we offer, and it is based on eligibility. So if an individual comes into our centers, we have actually 4 locations. One, we have our main location is in Yuma off of 16th Street and Avenue C. And then we have a small center in the Somerton area. I do want to say that we're proud of the Somerton because we actually opened that center during COVID. We didn't think we were going to be able to do it. We kind of delayed it, but at one point in time, we said, no, we need the service there. More on the South County side. So we did open the South County side more in the Somerton. And then on our north side of Yuma, we have our youth center, which we serve our youth. And we also have a small center here in San Luis, Arizona, off of, let's see, next to, I know it's next to Regional Center for Border Health, but it is a small center. It's like a 600 square feet, but it's more of a resource center. So an individual that's living in the San Luis, Arizona area can go into that center, get information, and then follow the rest of the process to try to get our services. So here are some of the services that we offer somebody that's at no cost to them. We have access to computers and internet access, copiers and fax machines. We have to make sure that we're ADA accessible. Again, talking about veterans and spouses of veterans that we provide services. Referrals to other partners or community resources, because we do need other community partners to help us with, it could be some type of a rental assistance, or it could be utility assistance. So we have a wide variety of partners that we work with, so we can also refer them to them. If they're eligible for our program, they can receive a WI orientation, which means that they get an overview of what our services are and how they can benefit from those services. And then as well as training and work-based learning, which I'll kind of cover a little bit later. And then the ultimate goal is, again, employment opportunities for these individuals. These are pretty much some of the services, it's not all, of what we can offer an individual if they're an adult or on the youth. They're very similar on some of the areas that we provide services are, but on our youth, we do have a lot more services that we offer them just because they're youth and they need more assistance with that career pathway. So job assistance, you'll find it in both areas, career counseling, resume and interview preparation is very key when we're trying to place them with employment. Trainings, that's one of our main areas that we provide services is with trainings, short-term certifications. And then work-based learning, again, I'll have a slide that talks about that. And then we have a partner three partners that we work with on basic education, trying to get their high school equivalency for those that have dropped out and don't have their diploma. We walk them through that pathway, and we use Adult Literacy Plus. We have the Somerton Adult Literacy, and then AWC also has a basic education program. On the youth side, what I did cover was we do job shadowings and a lot of support services. We find that the support services help our individuals because it cuts down on the barriers they might have to be able to successfully complete that certification, that training, that exposure to employment. We offer transportation, clothing. We have so many support services that we offer so that an individual can successfully complete their pathway they're following. Here are just a few of our training certifications that we offer. Below that, you'll see some of our agencies and community educational institutes that we work with. Arizona Western College, Regional Center for the Border Health, NAU, Yuma Truck Driving School. These are our four primary. We do offer online courses as long as there's a recognized credential tied to the end of it. We look at the length it takes. We do have a training cap that we have to stay within. So we'll look at all those requirements and see if that best meets the training for that individual. I do want to highlight that we recently added 3 of these trainings, 2 for Regional Center for Border Health and 1 for NAU. We did have the board approve these, and it was the, the Certified Medication Assistant and the Licensed Practical Nursing. So those are 2 huge trainings that I believe have been very successful in moving forward with that. So we're really happy that we have that. And then we also have our logistics and supply chain through NAU that we are hoping to move forward with providing some individuals within that training. We also offer services to our employers, and these are business resources. So anyone in the audience here that is looking for some of our individuals to place within either your organization or your as an employer, we do provide labor market data information. This could be from unemployment information to statistics on, what is the wages that an individual can gain during that specific training, their average earnings. So there's a lot of data we can provide an employer with this information. We also provide layoff aversion assistance, which means that we really want to get into an organization or an employer before they close their doors. Because if we can't get in and give these individuals resources, they are left without employment. So then where do they go next? It's hard for them to sometimes find those employment opportunities. So if they come through our door, or we can go on site before they do close their doors, we can provide them with resources. We'll bring a team in to talk about our program services, enroll them on site if they choose to do so. We also bring the Department of Economic Security's employment services and UI services, so they know they have some resources before they're laid off. We've even had employers come in and provide job opportunities before they're let go, but the employer has to be willing to let us come on site to provide that service so that we can assist them before they're let go. We do specialize in events such as we could post your jobs. We do a lot of hiring events and job fairs. And mainly what we do with our system, that it is a Department of Labor, Department of Economic Security state system, we have where we can match individuals and pre-screen them for you should you be interested in that service. And then we do have what we call the work-based learning. These are 4 types of work-based learnings that we offer for an employer. Some of you guys already use our services, so you guys are familiar. On-the-job training is very important because actually they're a direct hire from you. Once you're able to interview them, we pre-screen them for you. These are individuals that are coming through our programs, needing to find employment. They have experience, or they might not have that much experience, so they can vary. but you as an employer or an organization can vet these as well and determine, is this an individual that you want to interview? The reimbursement for that, or the participation of that, we're willing to pay an employer 50% of those wages back to you for 3 to 6 months, allowing this individual to come on your site, be your employee, and for 3 to 6 months, we can pay 50% of those wages back to you. Our internships and work experience are very popular. This is a service that we pay 100% to our client that's coming through and being placed at one of your work sites to receive experience, exposure, hands-on training. So the employer does not have to worry about workers' comp. They don't have to worry about the wages or how to pay the individual. That is all done through our program, and we provide that service to the employer. In connecting that with you guys making the time to train this individual in the skills that they need so that they can either, hopefully the ultimate goal is that you are able to keep them within your employer as an employer. If not, they can go back and put this information on their skills on their resume so that we can search for employment for them. Incumbent worker training is a service that we offer employers. If you have an individual within your organization or agency, that an example would be maybe they're their front desk person that now wants to become a CNA or go into another higher position, we could help what we call upskilling your individuals. With the upskilling, we will pay for the training that that individual needs to be able to be moved into that next position. However, it does have to be 6 months or less, the training, and we would pay the training. The employer has the benefit of not exceeding $12,000 per year for our program. So if there's a short stackable certification that's maybe $3,000, and now you have 4 other people, so you can literally have 4 people go into the upscaling piece of it, and we would pay that $12,000 to the employer back. So it's a great benefit. The registered apprenticeship, it is one of our areas that we're trying to promote and increase. It has been difficult to do that. It hasn't been, it's been a challenge, but we are not giving up. We're trying our best to get employers to go into the registered apprenticeship. We actually did a couple of lunch and learns and try to educate our agencies, employers about registered apprenticeships. But what we did was we stepped back and said, okay, how do we make this successful? How can we tell an employer the benefits of this? So the Yuma Private Industry Council, YPIC, did their first registered apprenticeship that was approved, and we're actually doing it within our IT department. So we're trying to set the trend and let employers know how long it took us, what are the benefits, so that we're hoping that more employers will take benefit from the registered apprenticeships. So we work with a lot of key partners and stakeholders, and it's important because we can't just do it alone. We need our employers, working with industry leaders. We actually work with our eligible training providers, basic education providers, community-based organizations, and economic organizations. I think this slide was talked about a little bit earlier on the Arizona rural healthcare transformation. I was able to get some information from the Office of Economic Opportunity. I can't even see the screen, but pretty much there's some grant dollars out there for healthcare, and they are looking at how to work with rural areas to increase those pipelines and opportunities. So here's just a slide that I was able to get from the Office of Economic Opportunity on, where the money's going to be put into as far as training, and there's percentages that are being put on there for those specific areas. Just what impact that we provide for the community. Alone this year, we start our year from July 1, 2025. Our enrollment for the youth was 300 and we're already at 226. And see the percentages. This is what we've already spent so far on work-based learning, trainings, and support services within our youth and our adult programs. So we're always giving back and giving that opportunity for our population to get hired. I don't know if I'll be able to play this, but here are just two success stories. One is someone we put into the police officer academy. He actually was a dispatcher, so he didn't have the means to be able to pay for the tuition. He came through our program. He was making about $22 an hour, and now he's making $27.95 an hour as being a police officer. And I don't know if he'll play it. I think you probably can't hear it. Just an individual that came that was interested in becoming a certified nursing assistant and finding employment. So they did go through Regional Center Board of Health CNA training. She completed that. She's now working at Life Care, making $16 an hour. So we were giving her that opportunity to do that, and she's successfully completed that. And just lastly, the impact we also do within our youth, I talked about a little bit about our charter high school. We do graduate at least 40 to 45 individuals. Last year, we did graduate 45. This year, we're looking at graduating 40. So these are individuals that we're going to be able to give them that high school diploma, enroll into our programs, or hopefully find employment out there for them. There are QR codes on here for any information that you might need. And thank you so much.
Thank you, Ms. Herrera. And now we have time for about 10 minutes for some questions for the panel that just spoke. Mr. Herrera, Mr. Cabrera, Ms. Herrera, Dr. Dreesen, and Dr. Johnson. And Raul and Andrea will be circulating the room with the microphone in case anybody has any questions. Just raise your hand and they'll come with you with the microphone. Okay.
Thank you. Yeah, this for Dr. Dreesen. I was wondering, looking at your admission rates for medical schools in Arizona, 7 medical schools, where do students go if they are not admitted to one of these schools? Do you have a sense for that? I know you mentioned Caribbean, maybe Mexico, but what I really want to know is if they do that, and what kind of numbers are we talking about? And do we know if they come back to Arizona?
Well, we know from the data set that the Arizona board data set, we know that some do come back. Quite frankly, I don't know the source. I don't know if Dr. Paul knows. I don't know the answer to the question.
A few added comments. Yeah, currently the average is 2 to 3 admission cycles before residents gets into a medical school. I don't think that's changed for a while. But yeah, I think it'd be an interesting thing to research. I think some students give up, some go overseas, some it's a mix of, but you know, repetitive application does help this many.
Thank you.
Just to share a success story.
We just recently had a CNA graduate from our program several years ago. That contacted us about coming and being a residency. Enter a residency family medicine program. She went to Guadalajara, did an internship at CHER Medical Center, and now is looking to come back to in Somerton. And she's out of Somerton. So that pathway coming back, we're really looking forward for her to be completing the School of Medicine in Guadalajara and then come to internship at CHER Medical Center and come back with us. I mean, that's a success story that we can tell you that hopefully that more like that come back to us. Right? But thank you for that support to the CNA program that put the seed into, and she just incredible flourished and became a doctor. Yes, yeah, it's a great story. Oh, yeah.
Well, I just want to say thank you for sharing that. I do believe that it doesn't do any justice me standing up here and saying, here's a success story. There's so many more that we can present to you in different occupations, but it's really good to come back and hear that this is the individual that we helped, and just by giving them that pathway that they probably didn't expect that they could get. So, you guys are the ones that help us with all that, and, we just try to provide as much services as we can to lead them to those success stories. So thank you.
Anybody else with any questions?
I am part of the Regional Center for Border Health. You have an IT here at the Regional Center for Border Health. So this is for Ms. Lydia, for Ms. Amanda. To add a bit, one more success story is you're looking at it. I went through that program at Arizona at work, which is what got me an opportunity to work here at Regional Center for Border Health. That program is amazing. It's something that I recommend to someone who went through that program. I definitely recommend it. They're very helpful to get you the skills, to get you everything necessary to work. And I want to say thank you to Ms. Amanda and Philip, the people here, for this great opportunity of participating by Arizona at work, which is now that I have at least 4.5 year certification of Center for Border Health. And for whatever, so I just wanted to say a big thank you, and then just to everyone else who recommended it. If you have anybody out there that can go through this program, definitely recommend it. So thank you very much. Just want to add that.
Thank you very much for that, Ms. I really appreciate your comments. Is there anybody else that would like, Mr. Ortiz?
I had a question for Dr. Johnson. One of the opportunities to talk about the shortage is at burnout. And I've noticed with our new generation that's coming into the workforce, they're really particular on mental health, which is great. It's a real conversation for them. They're more open and honest about it. And they're also open and honest about not being in debt after their college career. So I was wondering, with these pathways, what opportunities do you see about being open and transparent, but also what avenues exist to turn that burnout into something that's positive, and do you see an opportunity that we're leading our students to understand that there are opportunities when it comes to not being in debt when you graduate?
You for that question. But the first with debt and graduating, and it's important to have education and valuable careers, and in nursing, it is a valuable career. So proceed or access university. So Steve simply has had debt rates, or we have a lot of eligible students. When I spoke about the grant, the $7 scholarships, that's after all that is applied to the students. So for our students, many of their total package reimbursement is about $5,000 because of all the other things. So can't speak broadly that. I think that and I've always in my other occupation, my other employers as well, as talking about it is important to not take on more debt. So I think that we're easily price point for that. I love your question about mental health. That is one of my areas, self-care and mental health, that I'm very interested in. I actually did struggle with burnout early on in my career. There was not a lot of support for me, and I actually stepped out for 2 years from nursing based on that. And then when I came back to nursing, it was so important for me to share with my colleagues and co-workers the importance of our self-care, taking care of ourselves, and this concept of not giving all that we have, but giving what we can, creating those boundaries around that. So I've done that in a professional platform. And then now as a dean for the College of Nursing, awesome opportunity to help our nursing students understand the importance of well-being and their mental health. And we do not just our generation, our younger generation of students who are more maybe vocal about mental health concerns that they have, but this is something that has existed for quite some time in our society, and for nurses who struggle a lot with the emotional stress and the burnout. So in our curriculum, actually, in our undergraduate and our graduate curriculum, we've embedded opportunities for students to practice well-being and wellness. We have content around that. And I give that my DMP students, we did our defenses for doctoral students. And the student that I chaired loved her project, and it was actually entering, having an intervention of just 3 mindful practices for students. Measure their perceived stress at the beginning of the semester, midpoint of the semester, and at the end of the semester. Traditionally, nursing student stress is very high, very competitive, high stakes program when they come in, and it just increases throughout the program to graduation. And her study, it showed, and her project, it showed that yes, it increased at a midpoint and it actually decreased at the end of the semester by implementing mindful practices as simple as deep breathing, positive affirmations, guided imagery. And so those are things that we're implementing throughout our entire programs to help students decrease their perceived stress as well. I could talk for years about this, but thank you for that question.
Thank you, Dr. Johnson.
My question is for Dr. Grayson. I got some emphasis when you mentioned about the 10 licensed physicians from Mexico, but I think you were going to contain extra information regarding that.
It's shown in the table, 10, it's around 10 physicians currently getting licensed in Arizona. In Yuma are graduating from universities. We also know through referral from Amanda talked to the Tucson Medical Center program in Tucson, and they have formal arrangement with First Guatemala, and they do rotation, they share rotation and have visiting resident programs. They have a series of formal collaborations. We've had, I don't know if our colleagues from NC County are here, but we've started conversations around trying to develop similar avenues. But it seems like a natural fit because we have neighbor institutions, people that know the weather, they have family in the general area. It seems like a good fit where we could actually invest in training, further training, and then keep the physicians here. So it seems like a good opportunity would be, I think, important to establish those relationships. There's certification issues that have to be addressed. There's a variety of issues. It would not be an easy process, but it's something I think that should be really productive. Thank you. And there's a poster session downstairs that will be attended, so I'd be happy to talk more and think more downstairs.
I think we have time for one more question. I'd just like to remind our speakers, please hold the mic a little closer to your mouth so that we can so that we can all hear. We have a few more questions. Go ahead. Yes.
Questions for Dr. Johnson. Thank you for all the work that you're doing in closing that gap. But you mentioned that there is only 30%. There are only 30% of the students in nursing stay down to by the graduates. That was the number that I saw. So that means 7% of them. Arizona, is that what I heard? Okay. Okay, so if you could just like let us know more about the actual percentage, and then the work that you're doing is fabulous. When do you see that gap close?
I don't see the gap closing within
Or
the
even
next
narrowing.
decade, but I think narrowing a bit. The one thing that I said that was about percentage that stays was for our graduates, and we have 80% that stay in Arizona. And so that's where I feel that we are helping to address that gap. I wish I had one of the slides that was shown previously as well, how many students were graduating in Arizona from the different universities. It is a small number, somewhere around 1,000 students, yeah. And so then when we're looking at that gap, we're not at all producing enough nurses to address that gap. So I think that again, it's existed for quite some time. It's growing with the population we have. We'll see a little bit of a normally off when the baby population, just our largest population right now. You're not seeing them with comorbidities as well, but I don't see that. The thing that we are super proud of is the number of graduates that can stay in Arizona and practice. That's okay.
Thank you for that. And with that, we're going to conclude our. Oh, one more question
to that. One thing that we have noticed regarding to that issue, because it's not just about the shortages, it's the family that comes with it, right? And the ancillaries as well. One thing is childcare for a family. If a nurse is coming to the region, I'm talking about just the region area, and it's something that we've noticed. It's been for decades now. If there are no opportunities in the region, the family will. If there are opportunities for the spouse, in any area other than healthcare, the family will not stay. So that's one gap that at least has kind of been out there more and more. And for what we've been trying to accomplish is obviously push the healthcare, but also the innovation of other areas that can bring the whole family here to work. And that's why we're kind of developing a 65-acre downtown Yuma on innovation and research and development. Because we see that for many gaps on several organizations, if there is no, I'll go back, if there's no opportunities for the entire family, and that includes elementary, middle school, and high school areas, if they don't see that there is an opportunity for them here, they will. And I asked Dr. Dresden if how many of those doctors actually came from Yuma.
We don't know. We know, having been at some ceremonies at the University of Arizona, the white coat ceremony in particular, and they call upon the students. Oh, I'm sorry. We don't know from the data set we have where the origin was of the physicians, but having attended a white coat ceremony also at the university, they announced during that, when they first get into medical school, they announced where you're from. And actually there was a surprising number, 10 or 15, that there was a great deal of applause when they announced the Yuma residents. I think there is a Yuma cohort. I don't know what the size of it is, and it should be bigger.
Yes. The other portion is salaries. It's a huge portion when comparing to Maricopa and Pima, they have the most. Yuma Center, which is great. Salaries also play a huge role on how we're going with the state of Maricopa. Sometimes we call it that, but but with Maricopa, that whatever difference of salary, that's a huge incentive for people to not stay. It's unfortunately, but that's the reality. From engineers to healthcare doctors for now.
The different kinds of, an additional comment I was going to make is that was the call to have better access to their recruitment, their selection, and their placement information, which is really hard information to get.
And I say this because we serve a lot of the high school and college students and university levels as well. And obviously that's one of our goals for them to stay. But if the opportunity is not here for the different whatever company and organizations, they will leave. Unfortunately, that's what does occur. But we'll try and change that. Obviously, go back to we're 1.7 million. We have opportunities.
Thank you all for that discussion, and we'll be able to continue it a little bit later with the next panel. For now, we invite you all to go downstairs to the poster session. We have about a 10-minute break. We ask that you be back here promptly at 10:40 so we can continue with the program, please. So please go downstairs and go ahead and look at the poster session. Thank you. Thank you all. And we hope you enjoyed the poster session downstairs. And as everybody's getting settled, I'm going to go ahead and introduce our next panelist for the next part of our agenda, Border Research on Border Communities panel. And our first speaker is Mr. Bradley Schmitz, visiting researcher from the University of Arizona. Mr. Schmitz is a visiting researcher at the Yuma Center of Excellence for Desert Agriculture at the University of Arizona. He received his PhD from the U of A in Tucson and previously completed two postdocs at the National University of Singapore and Johns Hopkins University. He is leading YCEDA's One Health program and executing projects along the Arizona-Mexico border in collaboration with local public health agencies and the Arizona Department of Health Services. Please help me welcome Dr. Bradley Schmitz.
All right, let's practice here. All right, so I start off with contributions first. And just so everyone knows, I have a lot of slides and I get really excited, especially they're making cake and I'm like getting ready for lunch. So I hope you guys are too. But I want to mention everyone who's been involved in this project before I get started, just because we'll see how much time I have. I want to make sure everyone gets their credit. But our entire team is the first list of contributions of our research technicians in the laboratories, as well as those that work with us throughout the country. So although we are based here in Waisita, we have several PhDs that are throughout the country that have contributed to this quite significantly, as well as our partners, Regional Center of Border Health, Arizona Department of Health Services, the University of Arizona, all the municipalities within Yuma County, as well as Yuma County. We are sponsored, or part of our project was sponsored by the Office of the Arizona Governor, and also TGen was important for our projects as well. So who are we? So I'm biased, but I work with the YCEDA, the Yuma Center of Excellence for Desert Health, and you guys would think that's a lot of desert agriculture. Well, I help focus the One Health portion. I'm biased, but I think it's the best portion. But Tanya would argue the otherwise. So I'm going to do a quick history lesson just so everyone gets caught up. And yes, we're going to talk about the pandemic and COVID, but the purpose of this is to really get you guys situated in what is wastewater-based epidemiology. So everyone here is probably familiar with the pandemic. I'm not going to go over that, but we can talk about on this slide, these are the reported cases in the United States throughout several years of the pandemic. You can see that they go up and down. There's a lot of stuff, but these cases really only show reported cases, and we try to delineate where your resources for public health action, clinical action should go. You can try to sparse out that data into certain hotspots, right? And usually do that based off of how we are reporting things. So we're reporting it based off of zip codes or counties or specific facilities, but most of the data we have within the state and the United States, the country is on county level. However, there are several limitations, numerous limitations actually to this data. There's testing availability. People would just not get tested. There's a lot of false positives or false negatives. People may go unreported, whether they're asymptomatic or they're symptomatic and said didn't want to go, or did an at-home testing kit, never reported those results. There's also lags, right? So you can get tested and then there's a lag. You might be negative and then 3 days later you would actually test positive. So you went negative and then you weren't sure, right? Or there could be a reoccurrence of infection. You said, oh, well, I had COVID, a month ago. I can't get it again, but then all of a sudden you did, and you just assumed that your symptoms were lower. It wasn't the case. And there's also vaccinations and breakthroughs with different variants of the virus. And again, I'm going to talk about kind of COVID. We'll bring it all back around to other things. Well, one way to get over those limitations is through our poop, right? So although we may not report things on our clinical testing, if it's in our system, there is enough science that shows that COVID-19, as well as many of the other pathogens we'll talk about today, will be secreted in your poop. And so that's one way for us to overcome those challenges, rather than relying on the population reporting themselves or reporting the clinical data. We can say, all right, we'll collect data through your wastewater on the community scale and have that be an additional tool that informs our clinical responses. How do we do that? Well, if you know COVID-19 is in your community, at the first part of that, you know that you can then collect wastewater at a singular point, which is either the wastewater treatment plant or parts of the sewage canals or whatever you can. We would go out and we would sample that. Yes, we had people go out in suits and actually pick out sewage and poop, put it in a bottle, bring it back to our lab. We'd concentrate it, go through a bunch of fancy laboratory mechanisms, and remove out all the poop, all the solids, all the liquid, and end with just the virus particles on a little membrane. And then we can utilize that membrane. We extract the DNA or RNA, and then be able to test that genetic material and give us an indication of what the general concentration is in that overall community. So how can you utilize this information to protect public health, right? So I mentioned there's a lot of clinical tests, but now we have this additional tool that can tell us what there is more COVID in our community than maybe what's being reported. Or we know that there's that lag period I mentioned. You can get infected with COVID and have 3 to 6 days before you actually show symptoms. Well, is there an early warning system that we can put in if we can detect it in our wastewater before people start showing symptoms, before it starts spreading out throughout the community more? Can we inform Regional Center Board of Health? Can we inform hospitals? Can we inform the state health department and say, this particular area is going to have an outbreak within the next week? Put your resources and focus there, put your staff there, put your testing kits there, put your vaccine clinics there. Let's make sure that we are targeted and have better resource management. So the first case of this, by the way, this is what I'm about to talk about. I'm super proud of this. The University of Arizona is the first institution in the entire world to actually utilize this technology and have a breakthrough that stopped further spread of disease. That technology has now been adapted throughout the entire world in different ways, but this case study is the first one in the entire world. It is now being probably one of the, it is the main case study that is cited in papers for implementing this technology. So again, we have defined communities. I talked about, well, maybe we can go to a wastewater plant. Well, a wastewater plant serves up to millions of people, right? And there's a huge sewage network that's really hard to understand. Well, if we get a certain amount of concentration of viruses in our wastewater system, well, where in the community is that? That's really hard to figure out. You have to go through the sewage system, collect a lot more samples. But if you go to a university, it's really defined. You know exactly what building students live in, and you have a sewage collection point specific to that building. The other part that's really useful of this, within your defined community, you can have targeted testing clinically on the specific individuals in those specific buildings. Whereas in your overall community, right, if we go out and collect from City of Yuma, where do we test, right? Where do we say who should we test? The whole City of Yuma? It's not really feasible, right? So this was a really good use case to say, we can target wastewater and also have clinical data that supports it and line these up and be able to utilize that information to form the rest of the world. This is how these two technologies line up. So we had 16 different dorms, all different types, co-ed. We had like apartments, shared rooms, non-shared rooms. It's just a quick story to show. There is a lot of detail that I left out because I only have 20 minutes because I could talk for about 2 hours on this one study. I'm serious. It's a really cool study. Again, I'm biased, but I'll kind of explain. In the beginning, coming into the university, all freshmen and anyone living in the dorms were required to test negative twice before entering, through their nose and through their mouth. Genetic testing and nasopharyngeal testing. So we knew clinically that they were negative. Then they came into the dorm the same day that they tested clinically negative, and we populated the buildings. We started testing that wastewater every few hours for 5 days to ensure that that was also negative. Okay, so then we were very confident that we've got negative clinical, we've got negative wastewater, and then classes started, right? And there started to be intermingling, and then people from the outside those communities, other students, teachers, wherever it may be, were coming in, and we started to see our first uptick within the wastewater without doing the clinical testing as rigorous. And when we got our first positive, that triggered a signal to, there was a bunch of work groups at the university that were working together to say, okay, let's do some targeted testing in those buildings. We were able to identify the individuals that were tested positive, some were asymptomatic. We were able to remove those individuals. And then as soon as we removed those individuals, within 2 hours, the wastewater went back to negative. So we were very confident at that point that we had removed every single person from the dorm that was infected and could potentially cause more spread. That story kind of carries on throughout these 16 dorms for a long period of time. But this graphic is showing that we're kind of monitoring it and we put shelters in place. You can see there's a drastic decrease, right? And so every time, this is an overall, but we have specific ones for each dorm. Every time we had a trigger that was positive, we go in and do that testing, remove infected individuals or people that tested positive, and you see the wastewater go back down. So a very powerful tool to have better resource management and targeted clinical interventions. All right. So again, that's proof to say that this technology can be utilized to help prevent disease spread. That's all published in this paper. If you guys are really interested, you can kind of enjoy it, I guess. But this is also a really powerful figure. Wastewater is not a typical diagnostic tool, right? However, we utilized it as a diagnostic tool. And what these are called positive predictive values and negative predictive values. And really what it means is how accurate is when you get a positive test in wastewater, would it align with there actually being somebody positive in that environment, and then vice versa. If there was negative, how common is it negative? You can see both of those are above 80%, close to 90% for the negative. For a non-clinical diagnostic test, that is extremely good. You think about all the different environmental factors that can go into this, right? You could have contamination of the wastewater. You could have somebody coughing instead of pooping, and that gets in there. All of those factors considered, we still had a really, really good diagnostic tool. And we utilize that diagnostic tool to then create what we call our levels of concern. And based off the specific concentrations we see within those defined communities, we could say at this concentration, we estimate that there would be this amount of people within that community at this stage of infection, meaning that it will continue a further outbreak if we don't do an intervention, or it's at a lower part of the infection cycle. Maybe we can monitor it, do some more additional testing before we cause that intervention. Again, trying to have that really specific resource management and intervention management. So we then adapted this framework into the border communities, why I'm here talking, right? So we adapted this framework throughout all of Yuma County. And so instead of utilizing those defined communities that are specific to the buildings of the dorms, we then define specific surveillance points throughout all of Yuma County within the 5 municipalities. We worked with the municipalities to identify where we want those selection points to be, what would be most efficient areas for that targeted testing, and then what would be most useful for relaying that information back to our clinical partners and public health partners in order to have the right interventions. So here's a map. Here's how we broke out the different points. These are sample locations, right, on the middle one, estimated population, and we're trying to get as low of a population as we can, right? While also understanding we can't sample every house, but we're trying to get the lowest amount because the fewer or the lower population you have, the more accurate you can be in your testing and the more concentrated you can be on those interventions. So within each of these, we have what we call a local surveillance and response team. So each of those municipalities, we broke it down, and it was myself or somebody at YCETA that was doing the wastewater testing, a local public health partner, somebody in the laboratory that's doing the testing who could translate the information appropriately, and then usually somebody at the wastewater facility who's collecting the samples, sharing the samples, understanding what's going on those days. Those specific, and so it's usually about 3 to 4 people. That small, what we call LSRT, collaborated together to basically every 2 to 3 days we are doing testing. Actually, every 3 to 4 days, sorry. Because we are trying to be ahead of the infection cycle of symptoms. So if you get infected with COVID, it usually has a lag of 3 to 4 days. So if we're testing every 3 to 4 days, you in theory can be ahead of when people are showing symptoms. Well, all of that information then gets shared upwards to our stakeholders throughout the entire county, and that's the steering committee. And then those individuals can basically tell us, we're having a festival, or we're going to have, we have lack of physicians right now, or whatever it may be, and we can all coordinate together throughout the county to figure out what's going to be the best response. So what were the actual responses that we put in place when we got some of these higher concentrations? So those LSRTs, it was just a quick email and phone call, typically saying, hey, in this specific area, we got a high alert. Within that level of concern I showed you, that chart, we'd say, okay, we're at a level of concern 2. That's really high. We should all meet together and think about what's necessary. So we would send these interpretation emails, and then we would that group, with the steering committee being educated on it, would come together with these different initiatives. So there are newspaper articles. We had mask recommendations in the city of San Luis. We promoted vaccination throughout the county. We also did steering committee updates that would say, again, here's what's kind of going on. Let's skip that slide. And that framework, we were asked, actually, got kind of voluntold that, hey, this is something that's really impactful. You guys need to put this and write this up as a framework in a publication that every places throughout the world can utilize. So everything I just explained is referenced as this Waters framework. So, and that Waters framework can be scaled to different buildings. The municipal level I described, the dorms I described, as well as specific building levels. And another great use case study of this, right? So then we worked at the university, we worked at the community scale, and then we said, well, specific to our border communities, there's a lot of migratory populations coming across the border every day to work, right? We have really a unique kind of population here, given the circumstances. And one of our partners asked us, again, this is published here, the Date Pack facility asked us, hey, can you utilize this technology within our facilities in order to help protect our workers that are coming across the border or don't have the same access to vaccines and hygiene? And so very similar to the graph I showed earlier, we partnered with the Regional Center of Border Health to where when we got a positive in the wastewater, that would immediately signal a conversation with the Date Pack management and the regional center. And within 24 hours, actually much less, maybe like 4 hours, typically 4 to 6 hours, regional center would go to the site, test all the individuals voluntarily, and make vaccines available to everyone. We had an over 95% volunteer acceptance rate or participation rate on every single one of these interventions that we had. And after every single intervention, when we tested positive person, remove them, always, every single time, over 8 times, the wastewater then returned to 0. And for at least a week, they would not have another clinical positive. So we knew that we were removing those individuals. The really important impact of that is that was a huge influence on keeping that business at a high yield, right? They kept their production going. They didn't have to suffer from lack of worker involvement. And all those workers were able to be identified, and they were put on paid leave so they could go home and just focus on getting healthy. We're expanding this right now as of last year from February through December. Actually, I skipped ahead. We started doing this for chemical constituents. And so we are now testing not just for pathogens that are listed here. These are a bunch of different viruses that we look at. And we do it seasonally. So we look at dengue or influenza, depending on the year time, as well as a lot of these different drugs that are being consumed, right? So we'll look at opioids, we'll look at caffeine, pharmaceuticals, and that gives us good clinical information about what may be being overprescribed, right? What may be being overutilized. What drugs may be being illicit drugs may be being abused within the community, or we could have specific targeted interventions to try to decrease that educational. I blurred them out because I didn't want to put them, but community A and community B are both based in Yuma County, right? So all this information I'm sharing here is Yuma County. We have this entire suite of chemical constituents. If you guys are interested in know what they are, I can show them. But we did this in almost 20 sites throughout Yuma County. So quite a big data set. And that was in collaboration with the University of Florida. And when President Biden was in office, he initiated this. So we are working directly with the Office of National Drug Control Policy, which is an agency inside the office of the president in the White House. Funny story, I did not know that the first time, and I jumped on a Teams call and I was totally like this in a t-shirt. And then like the president's staff gets on the line and I had no idea. And I was like, oh, cool. Thanks, guys. Thanks for letting me know. So anyways, takeaways. This framework can be very powerful. It's a really powerful tool that can help these interventions. It can help public health, can help resource management, especially within communities that may not have access to as many of these resources, such as Yuma. And then again, this whole framework is published and is being cited quite heavily across the entire world. And we're really happy that Yuma and all of our stakeholders are willing to participate in this, because we really are a kind of gold standard for the globe. And you wouldn't necessarily always think that, but we are. So thank you, everyone.
Our next speaker is Dr. Arturo Vargas, epidemiologist, Public Health District 6, San Luis Río Colorado, Sonora, México. Médico Arturo Vargas Velázquez, con maestría en epidemiología por la Universidad Autónoma de Durango, Campus Mexicali. Médico cirujano y homeopata para la Escuela Nacional de Medicina y Homeopatía del Instituto Politécnico Nacional en la Ciudad de México. Diplomado en Calidad, Seguridad y Humanismo en Medicina por primer nivel por los Servicios de Salud de Sonora en el 2008. Diplomado en Sangre y Componentes Seguros por la UNAM y el Centro Nacional de la Transfusión Sanguínea en 2012. Diplomado en Salud Pública por estudios de posgrado y Colegio Nacional de Alta Dirección Médico-Administrativa en México en el 2015 y diplomado en Epidemiología General por Servicios de Salud de Sonora en 2021. Diversos cursos, talleres, constancias que lo acreditan, tanto en instituciones de gobierno como en lo particular. Atención médica en el Centro de Salud Rural Golfo de Santa Clara, 2004 a 2009. Atención médica en área de urgencias del Hospital General de San Luis Río Colorado en 2009 a 2016. Área de epidemiología y módulo TB en el Centro de Salud Urbano de San Luis Río Colorado de 2016 hasta la fecha. Supervisor médico regional de epidemiología dentro del equipo de conducción regional de IMSS Bienestar en la región número 1, San Luis Río Colorado, de mayo 2025 a diciembre 2025. Docente de carrera de enfermería, nutrición, criminología, fisioterapia en US de San Luis Río Colorado en el lapso de 2017 a 2024. Atención médica en área de urgencias en la clínica ISTE de San Luis Río Colorado desde 2012 a la fecha. Bienvenido a doctor Vargas Velázquez.
Muy buenos días, muchas gracias a Manda Aguirre por su oportunidad de participar en este simposio. Muchas gracias a todas las personas que nos han escuchado. Y tengo un inglés muy lento, así que mi presentación va a ser en español. Muchas gracias. Panorama epidemiológico es una definición que se ocupa para tener una conciencia o una idea de cómo se están comportando las enfermedades en una región específica. La epidemiología maneja tres variantes bien importantes: el tiempo, el lugar y la persona. Cada situación que afecta a una comunidad puede verse diferente dependiendo de esas variantes. Entonces, en esa población específica es donde se ve la situación que se puede estar presentando, y en el caso de la epidemiología trabajamos sobre lo que es poblaciones generales. Ya no nos ubicamos a un solo individuo, nos ubicamos a todo un padecimiento o a toda una situación que puede afectar toda una población. Entonces, el panorama epidemiológico nos permite darnos una idea, un concepto de cómo se está manejando, cómo está viendo esa situación de una enfermedad. El tema anterior, sumamente interesante, ¿no? Una técnica más, una manera más de identificar enfermedades con un producto biológico. La Secretaría de Salud ha modificado o ha buscado la unificación de la atención en salud. Por lo tanto, ha modificado también su plan de atención primario. Este plan de atención primario está basado en una estrategia en la cual se busca que el IMSS Bienestar, en apoyo y en regencia de la Secretaría de Salud, trabaje para mejorar la calidad de la atención en las personas. Entonces, este modelo de más bienestar empezó en México en el 2020, en el 2018, empieza con este modelo de atención específico con trabajos específicos a la salud. Y podemos ver lo que viene siendo las acciones de la atención a la salud en los modelos integrales dentro del ciclo de vida. Por lo tanto, hay acciones que se van a ir en dirección hacia la población, ¿verdad? Y que van a estar regidos por los distritos de salud. Les presento lo que viene siendo el sistema de vigilancia epidemiológica en México. En México nos regimos desde el nivel federal por todo un sistema que tiene vigilancia específica. Como pueden ustedes ver, la Secretaría de Salud se maneja a través de plataformas, a través de información que vamos cargando cada una de las unidades operativas y que puede ser revisada por cualquier persona con acceso a niveles de información en epidemiología y que nos permite hacer planes y trabajos específicos. Pongo un ejemplo, estamos viendo una pandemia de sarampión que ha afectado, inició en el norte del país, en Chihuahua, y empezó a atacar ya el centro del país, pero también pudo atacar parte del estado de Sonora. Y han tenido casos en Mexicali. Gracias a esta plataforma se establecen estrategias para poder controlar ese tipo de brotes y actividades. En este caso, la directora del Distrito de Salud 6, la licenciada Sandra Salazar, ha hecho una estrategia para poder blindar a la población de San Luis a través de que toda la población migrante que llega a la comunidad le invita, la asesora para vacunarse y eso nos ha permitido hasta ahorita, después de casi un año de brote de sarampión, de poderlo controlar. Vamos a hablar exactamente de lo como se ha presentado esta situación del brote de sarampión y normalmente lo manejamos nosotros desde un punto de vista nacional para poderlo llevar hacia el punto de vista estatal o zonal. Y vemos que, por ejemplo, en esta gráfica, que es la herramienta que utilizamos en el área de epidemiología para poder manejarla, vemos que en esta gráfica estamos viendo que hubo un aumento de los casos de sarampión que se aumentan y que se empiezan a buscar. Aprovechando la ponencia anterior, sabemos que necesitamos tener casos confirmados y casos sospechosos. En México se buscan todo caso sospechoso que cumpla con algo que llamamos definición operacional. Toda aquella persona que se encuentre entre los 6 meses hasta los 49 años de edad, que cumpla con fiebre, un exantema, ¿verdad? Coriza, un malestar general, un cuadro gripal y que además tenga un exantema, ¿verdad? Lo manejamos como un caso sospechoso. Este caso sospechoso pasa a una testificación clínica, ya sea por un médico clínico, por un médico especialista, un pediatra, y de ahí nos notifican a lo que es vigilancia epidemiológica y valoramos hacerle las pruebas necesarias. Entonces, en México se han hecho suficientes pruebas para buscar y hemos tenido casos de enfermedad febril exantemática, 33,000 casos, de los cuales se han confirmado hasta la fecha de marzo 26, se habían confirmado 13,000 casos en todo el país, de los cuales se habían logrado descartar 15,000 y todavía se encontraban en estudios 5,497 casos. Esta misma situación se presenta y nos da la oportunidad de ver y de poder estudiar en qué población es la que tendríamos que tener mayor enfoque o objetivizar nuestras acciones. Podemos ver que el grupo de edad que ha tenido mayor cantidad de casos es el de 1 a 4 años. Por alguna razón hemos detectado que hay una disminución en el apego al esquema de vacunación en el caso de México. Hemos visto situaciones como fue COVID, que muchas veces hay información no validada que consideran que las vacunas pueden provocar otro tipo de trastornos y eso nos ha provocado que nos haya bajado el apego o que nos haya bajado la cobertura de vacunación. En el país, a nivel nacional, los mayores casos los encontramos en jóvenes, en hombres y en una población entre 1 y 4 años. En esta tabla podemos ver que a la actualidad el estado con mayor problemas o con mayores casos identificados y estudiados de sarampión es Jalisco, seguido por Chiapas. Para nuestra situación, no aparecemos en el estado de Sonora, sino aparecemos hasta el lugar número 8, ¿verdad? Actualmente con 163 casos. Lo que nos permite analizar en esta gráfica o en esta tabla es que esos 163 casos que se han buscado, la mayoría se encuentran concentrados en la ciudad capital, en Hermosillo. ¿Cuál es la causa? ¿Cuál ha sido la situación que se ha observado de estos casos de sarampión? Es que ha sido población que es migrante. No hemos tenido una población originaria o que se haya ido una transmisión dentro de la misma población de Hermosillo, ya que el brote que inició en Chihuahua inició en población agrícola, en población que se dedicaba al campo. Y esta población migró de Chihuahua a Obregón y de Obregón ya migraron a Hermosillo, a Caborca, De esa misma población, algunos migraron a Baja California, sobre todo en el Valle de Mexicali, en el campo agrícola de Mexicali. Y es donde podemos ver que esos casos se han concentrado. Desgraciadamente, se han presentado, en Sonora se ha presentado una defunción, pero la mayoría de los casos ha sido, en este caso, en esta situación de Sonora, nuestra población de mayor afectación la hemos visto en la población económicamente activa, una población entre los 15 y los 35 años, siendo mayor la distribución en la población masculina. Esta es la curva que tenemos de casos confirmados de sarampión hasta el 18 de marzo en el estado de Sonora, siendo 163 casos, ¿verdad? Y esta sería la distribución que tendríamos. Hay que aclarar que en la situación de nosotros, en específico, la frontera que nos interesa, San Luis Río Colorado, lo que se ha hecho es blindar, seguir, convencer, empoderar a las personas que necesitan cuidarse y se ha trabajado para poderlos cubrir contra el sarampión. Afortunadamente, a pesar de la búsqueda que hemos tenido de todos los casos sospechosos de enfermedad de febril exantemática en todas las instituciones de salud, ya sea IMSS ordinario, IMSS Bienestar, Secretaría de Salud, servicios municipales de salud pública, clínicas privadas, no hemos encontrado todavía un caso sospechoso, pero sí se ha logrado y se ha cubierto hasta 143 personas para poderlos cubrir contra el sarampión. La siguiente situación que afecta el siguiente padecimiento que nos crea un impacto a nivel del panorama epidemiológico en esta zona es una enfermedad que ha afectado también a nuestra ciudad hermana o nuestro estado hermano, que es Baja California, que es la rickettsiosis. La rickettsiosis se ha vuelto un tema de importancia para la Organización Panamericana de la Salud, porque es una enfermedad que si nos atrasamos en el diagnóstico o en el inicio del tratamiento, su mortalidad es alta. En México hay 3 estados que tienen la mayor causalidad de casos de rickettsiosis o de fiebre manchada de las montañas rocallosas. Son el estado de Chihuahua, Nuevo León y Baja California. Y Sonora también se encuentra dentro de los estados prioritarios. Podemos ver que en el año 2026 Sonora le gana al estado de Baja California y se presenta con 16 casos, con una tasa de casos de 0.5 por cada 100,000 habitantes. Estos 48 casos se vieron hasta la semana epidemiológica número 8. Normalmente en epidemiología dividimos el año por semanas. Por lo tanto, un año tiene 52 semanas y es lo que nos da tiempo de utilizar la variable de tiempo y también nos permite poder observar o ver el trazo de una enfermedad a través de los años para poder hacer un canal epidemiológico. Aquí podemos ver en esta gráfica los casos y defunciones de fiebre manchada por entidad federativa. En el 2025, afortunadamente, Sonora solamente tuvo 6 defunciones de 16 casos, mientras que Coahuila nos presentó 4 casos con 3 defunciones. Sigue siendo importante aquí, aunque sea una cantidad de casos o una tasa baja para la población, la importancia es el impacto por la alta mortalidad que tiene esta enfermedad. Podemos ver en este caso la distribución de casos por distrito de salud, ya hablando de Sonora, en el año 2026, y los mayores casos que hemos visto es en una población de niños y se ve en población entre los 6 y los 24 años. La mayor cantidad de casos que hemos podido identificar de rickettsiosis en el estado de Sonora se han concentrado en la capital, que es Hermosillo. La causa, nuestro hospital de referencia infantil y nuestro hospital de referencia general, y los casos complicados que cursan con un cuadro de septicemia, los tenemos que mandar para allá para poder mejorar su situación clínica. En el caso del distrito 6, que comprende las localidades de San Luis Río Colorado, el municipio de Plutarco Elías Calles, Sonoita y Puerto Peñasco, hemos visto un 4% de los casos totales. Esto se ha visto en la población de Puerto Peñasco principalmente. Tiene aproximadamente 3 años que están teniendo una incidencia alta con estos problemas de rickettsiosis. Aquí podemos ver que en esta tabla que la hemos manejado, tenemos que los casos de rickettsiosis, hemos visto 4 casos hasta la semana 26, desgraciadamente con una defunción, y durante el año 2026 se han estado 177 casos 171 casos y hemos presentado hasta 23 casos y 8 defunciones. La distribución de los casos de riqueza por nuestro distrito de salud, vemos que la mayoría se encuentran en el municipio de Puerto Peñasco, mientras que el municipio de Plutarco Elías Calles no nos ha presentado casos. La siguiente enfermedad y la última que vamos a platicar y que también tendrá importancia y que se ha estudiado es el dengue. A nivel nacional, ¿verdad? Y yo creo que también es de importancia para la OPS, el vector del mosquito Aedes aegypti y sus subespecies nos han causado ciertas problemáticas y tienen mucho que ver con la salud pública. Podemos ver que en este año se han reportado 977 casos, teniendo mayor prevalencia el estado de Sonora, Sinaloa y Veracruz. Y nos sigue Baja California Sur con 54 casos. En la semana epidemiológica 9 del 2026, ¿verdad? Podemos ver que hay una prevalencia de 6 casos y afortunadamente no ha habido defunciones. Aquí tiene mucho que ver, hay que aclarar que se ha mejorado bastante la capacitación en el personal médico de contacto a nivel nacional y es mayor y es mejor la clasificación del dengue. Por lo tanto, la atención oportuna se ha visto mejor. Lo detectamos más, pero afortunadamente hemos tenido menos defunciones. En nuestra zona, en el distrito 6, en San Luis Río Colorado, podemos ver que al corte del 11 de marzo del 2026, afortunadamente nada más habíamos tenido 4 casos en estudio, de los cuales 2 habían sido confirmados. Esta población había sido migrante, afortunadamente, venían del sur del estado, donde hay circulación ya local, ¿verdad? Y fueron controlados y fueron dengues no graves que tuvieron una buena resolución. El Departamento de Inteligencia de Salud dirigido por la licenciada Sandra, en coordinación con la licenciada Carmen Vargas Angulo, se encargan de emitir un boletín epidemiológico que nos reparten a todo el área de epidemiología de la zona para estar al pendiente y estar informando a la población. En este boletín epidemiológico, ustedes pueden ver que afortunadamente los casos confirmados hasta el 11 de marzo seguían siendo 2 y que no hemos tenido defunciones y que hemos tenido una clasificación del dengue en dengue no grave o lo que podemos encontrar como fiebre por dengue. El manejo de este tipo de casos es ambulatorio sin necesidad de que haya complicaciones o de atención hospitalaria, pero el porcentaje de estos, cuando la tasa de incidencia es mayor, el porcentaje es hasta del 15% en dengue grave, los cuales ameritan atención hospitalaria y aumentan los costos tanto para la familia como para las instituciones. ¿Alguna pregunta? Muchísimas gracias. En las páginas de la Secretaría de Salud, ¿verdad? La Dirección General de Epidemiología, el mismo boletín que se emite a nivel distrital, pues se emite a nivel nacional por semana epidemiológica. Entonces, son abiertos a la población, se pueden analizar muchas veces canales de 5 o 6 años y podemos bajar información para ver la manera en que se está manifestando. Gracias por su tiempo.
And there'll be a little bit of time for questions for the panelists after our next speaker. Our next speaker is Mr. Dr. Todd Pierce, Principal Investigator, AADI. Dr. Pierce is a medical and applied anthropologist with more than 3 decades of experience conducting field-based research on health risk, human behavior, and upstream prevention in community and operational environments. He is the founder and director of the Isla Mujeres Ethnographic Field School and principal investigator of the American Agricultural Defense Initiative, where he designs real-time risk detection and prevention models linking workforce stability, disease exposure, and production continuity. He has led and contributed to federally funded multi-site research on infectious disease transmission, behavioral risk networks, and community health interventions, integrating rapid field assessment methods with operational decision support to identify drivers of avoidable medical utilization. He holds a PhD from the Catholic University of America, an MA from Yale University, and a BA from the University of Connecticut. Dr. Pierce also served as a light infantry platoon sergeant in the U.S. Army National Guard. Thank you for your service, sir. And informing his operational approach to field logistics and risk management. Please help me welcome Dr. Todd Pierce.
Hi, thanks a lot. So I'm a little different than everybody else here. I'm an anthropologist. But I want to thank Amanda, first of all, for inviting me and bringing me here to show me this amazing place. I've always loved deserts. I don't know why. I like them. And also to the other members of your team who have really been helping me out here. Now, for everybody knows, Amanda and I met almost a year ago now, and we've been meeting every Friday, every week for about an hour to develop out something new, something different, a different approach. As an anthropologist, we look at things holistically. We want to think about different parts of aspects of culture and how they interact together, right? So when I first got involved in this kind of research, it was at the forefront of the HIV pandemic. And so there were a lot of people dying, late 80s, early 90s. And if you asked NIH or the CDC what an anthropologist was, they couldn't tell you. So we had to make them understand that they needed us. And with our data, our level of data on the ground, we use what's called ethnographic research, qualitative data collection and analysis. We can get into the ground where the people live, how they interact, find out little things that epidemiologists might not think of, or other medical scientists might not think of within their frame of perspective, right? So that's our job. Now, when we're talking about this new project, I really can't see these slides, but there they are. Oh, it's right in front of me. Okay. I'm not used to this stuff either. We're talking about here with the Yuma situation. We're really talking about a way of approaching something from a different set of eyes, right? So I had to mess around with different theoretical models, and some of you guys might be really familiar with harm reduction, right? Designed primarily for drug users and to make their body healthier, to reduce harm within it. So let's say that heroin is the issue. Okay, we can't remove heroin because they're not going to stop using heroin, right? Anybody who works in addiction, we know how this goes. What we're going to do is we're going to reduce other types of harm on their body. There's and then we're going to now let's take the idea of syndemics. Syndemics is essentially when you have multiple factors happening at one time on the body. So you might have things like diabetes, high blood pressure. You might have dengue fever. Where I live, that's quite common. So you might have a lot of other factors in the body that are happening besides whatever else is bad, like heroin use. Now let's think about Yuma, Arizona as a body. And let's remove the name Yuma, first of all. Let's think of the region as one body. And there's one thing that happens here that is harmful to that body. And it's harmful in many ways. We'll get to those things. But that one thing is agricultural production. Okay, just as straight up, the Yuma, Arizona agricultural workers are 3 times the health risk of any other region in the United States. So that alone should trigger a different kind of response. So how do we think of like this body now? The body is, well, first of all, it's all of you too, right? They're connected systems of a network. And this is considered a network with many networks within it who are trying to coordinate by having events like this event and sharing what we're doing, our ideas, our successes, and our dreams for the future, right? So we're all working together as a network. Now, if we think about the Yuma body as one thing, and the agricultural production is the issue, how do we reduce harm within that system? So let's see if we can get back to my actual slides here. Standpoint. You're going to hear me say a lot of things that have already been said today because they're important things. I think that each of the speakers today has brought this idea of syndemics without saying it, right? And structural stress and resiliency, which is important too. So what we're looking to do here is to, am I in the right one? Probably not. Wrong way. Slide 1. Right now, we can detect patterns pretty well, and we just had a good example of that with the waste management study, right? So we can predict these things. We can also predict, we can detect dengue, for example, or other diseases. When we see that happening, we already know there's a problem, right? That problem is part of a larger structure. We can get ahead of the problem, which has been proven with the waste management detection. But how do we detect where the problem might come from in the first place if we can't see? Now, we all have blinders, right? Like a racehorse does. We don't realize they have blinders until they come off. And you go, oh, I totally missed that. Couldn't see from that perspective. That's the way we see the world, right? So from an anthropological perspective, you want to try to force those blinders off as much as possible. And one way to do that is by having colleagues like yourselves to say, hey, Todd, you forgot about this point or that point, right? So you guys are my natives. And I'm studying my culture, right? Like an anthropologist would do. So we can think of that level of our network. But then we want to think about the individuals who are out there working the field and what are they dealing with, right? So that's, we need to skip this slide. Let's go back to my notes here. So that's our core idea for the project. And what we're trying to move forward through is making system precision. Now, last night, precision in a system, I'll think of again, this network is a system. We're all part of that system. We're all part of that one body. Last night, I was at the Cocopa Casino. Fabulous place. If you've never been, yeah, great chicken wings. It was amazing. And a great place to observe people. So I met a guy there who is retired. Well, he's not retired, but he was in the Navy. He was an electrician. He was trained by the Navy being an electrician. And he's pretty good one now. He's in charge of cold storage, freezers, and refrigerators for food. And he also does this. He said he worked on Amanda's new building. He did the electrical for that. So he's well tied in. I said, well, okay, well, we're just at the bar talking. It's a native, right? He knows what's going on. I said, I bet you got some stories. I bet you know how things break. And he said, oh, let me tell you, I've seen whole giant, storage units is thrown to the garbage because it was off by a half a degree. He's part of the system too of health, right? So getting that level of stories, these vignettes, is what helps us understand that body better. What can break? What can be fixed? How can we go now, more importantly, upstream, beyond detection to prevention upstream, which is going to end up not only making people's lives a lot healthier, but also at the end of the day, it's going to save the industry billions of dollars. We'll get to that in a little bit. So we're looking at syndemic risk environment. Now, we already know that part of the problem with being 3 times that health risk of other places is we have the environment, the heat, the stress of the body, the transportation of bodies, people being close together. What does that do? I'm sure Bradley will tell us. It makes people at greater risk for transmission. So we see things like not just COVID, not just perhaps dengue as well, but we're seeing tuberculosis and other types of diseases that are coming forward. How do we get upstream of that? Well, a lot of it's kind of a no duh. You put people in cramped housing, right? And you put them in cramped transportation. Well, can we reduce the harm on that? I don't know. Perhaps not. There might be some structural issues that we can't change. We just can't change that aspect. That's part of the agricultural mainstay that we can't remove. We have to keep that going. But maybe there are some things we could do, air filtration, things like that. But understanding the individuals who live there, that what is your life like? And then you find out, well, 60% of these workers also have diabetes or whatever the number might be. Or they might be dealing with things like childcare, or somebody in their family is also sick. They're going to take care of them. That is part of the body. So let's take the individual now. It's a cell within that body. And the body's not going to be healthy until we can address all these issues at once. So that's what a systemic approach is. How do we do that upstream and change things is where we get into logistics that are difficult, right? So we're looking at prevention as infrastructure, actually building it into the infrastructure, which means getting anthropologists on the ground, but also working directly with epidemiologists, promotoras, local healthcare workers, and people like yourselves, and also we have the government to deal with. Right now, we are dealing with structural issues, parameters, you can call that, under the current administration, that our normal funding routes have been eliminated. So we've been struggling with that. Amanda can talk more about that than I can probably. But we're moving forward and still developing the science and building relationships within the community. And I'm so glad that Amanda brought me here to be able to meet some of our counterparts on the other side of the border. Well, the same side I live on, but to really coordinate, because they are part of the body as well. So getting upstream also means working with the farmers and producers themselves. Amanda's already reached out, and there are farmers who want to work. And you brought up 95% of the testing was all voluntary, and there's only one reason why that happens: trust and community, right? And I think that our first speaker, he also brought this issue up too, about trust and community. Luckily, we have that with Amanda's teams, so we can get people to open up and talk to us about their lives on the ground, because that's where you're going to find out. We're not here to tell a farmer how to do his job. He knows, and he also knows where the problems are. But is there a way for him to express that? Is there a way for him? Does he feel empowered enough to express it? Is it something that maybe they're afraid of the economic impacts of discussing it? So how do we bring that all together? And that has to do with a level of trust, monitoring, but getting us upstream to prevent this. Right now, over 3,000 people a year die from E. coli poisoning alone. Now, there's also thousands more who survive it, but they're not going to work that week. And they probably have a family member dealing with them, taking care of them, which takes them out of work. And also the economic fallout across America is somewhere closer to $75 billion, about 17.5 of which is direct medical. So that alone right there should be, okay, well, if we want to use an economic argument, which a lot of politicians like to use, and business people, then that's one for you right there. But how about saving 3,000 lives and making tens of thousands of lives a little nicer too, right? So that's one way of addressing this body, is how we scale out to the world, right? When there's one outbreak and they say it's lettuce, no one in America is buying lettuce that week. That's it. The loss is huge. So how do we address this at scale? Now, similar to what what Bradley's project did was to be able to think of prediction. So we can think of outbreaks, how we get upstream of it, and how we can scale this to other industries as well, not just agriculture. So what we're trying to do here is just establish a way of how we think of food production in a holistic manner, get upstream of it. So it could be beef, it can be fisheries, it can be all that. So how Yuma would be basically the developmental ground for a new way of approaching food production, critical infrastructure. And yeah, it's a lot, but it's like coordinating an orchestra, music. You have different sections of musicians, they're all doing their job. When you pull it together, then you have your composed song. And that's what we're trying to do. And it's been a difficult process given our political environment, but we have enough specialists on the ground who know their job. And we're going to need more of them too. So I'm really glad, it's tough because, as you mentioned, you already have under strain for like your structure of nursing is already at a critical, like you need doctors, the same, right? You've already predicted you will have this loss in 4 years. How do we get ahead of that? That's predictive structural constraint. That's part of this body as well. We need younger people to be encouraged and supported through these things. And also, I'm really glad you brought up the whole burnout thing, because that's tough for the younger people. I also, because most of my work was done in shooting galleries and crack houses on the streets, prostitutes and drug users and drug dealers, right? So most anthropologists last about 3 to 5 years in that environment. I did it for 20 years. And then I was like, all right, I'm gonna take a break. I moved to Isla Mujeres near Cancun. I opened a little school, and now I train ethnographers how to do research. And we design projects constantly, working with community members, with partners. So I'm getting back in the field with Amanda, and we're going to make a great project at scale. So keep your eyes open for that. We call it the Yuma pilot. It's simple, but we're looking to bring in this syndemics and harm reduction merge to apply that to agricultural production, moving it that perspective from drug use or from other diseases to bring it why not apply it to a whole other system, a different body? Thinking that at scale is also the individual's story. So glad to meet you guys.
And before we continue with our question and answer session, I'd just like to take a moment to recognize Maestra Claudia Martínez, who is here en representación del titular de la Comisión del Estado de Ecología y Desarrollo Sustentable del Estado de Sonora. So, welcome. Bienvenido. And now we have about 10 minutes for some questions and answers from the panelists, if my colleagues would like to help me with the microphones. And if you'd like to raise your hand, if you have any questions for the panelists, we'll be coming around with the mic. ¿Algunas preguntas? ¿Alguien tiene preguntas?
Study, I'm just curious, I'm assuming they were doing this before the pandemic as well? Or were they doing this before the pandemic? And is this like a new research methodology or?
Yeah, good question. Yeah, this technology has been used for 20 years, utilized for enteroviruses and gut viruses for many decades. And the reason why the NORM study, the U of A was good when I did my PhD a long time ago, and I know I looked young, I'm not. We were doing like 14 different viruses out on campus and in Yuma County for about a 15-year period. And so we already had everything kind of at hand, ready to go. So as soon as the pandemic started, we were like, well, let's just add that in, right? Really easy. So we were lucky that we already had the infrastructure in place. But it's a pretty simple, and no, it sounds like it's pretty simple to perform, which is why it really kind of blew up throughout the rest of the world at the same time. So, yeah.
Hi, Tanya Hodges, the Executive Director of YCETA. So just, I really enjoyed your presentation and talking about, the culture that actually exists within our communities. And one thing that a lot of people don't know of is the high suicide rate of farmers, ranchers, and growers. So the jobs working in the fields at all levels are very, very high pressure. And I just wanted to bring that to everyone's attention, that it's not just the people in the fields doing the work, but at all levels, there's a lot of stress in producing food for agriculture. So thank you for that.
Thanks so much, Kate Ellingson from University of Arizona. Thank you to all the presenters. It's been really interesting. I have a follow-up on the wastewater-based epidemiology, and you kind of talked about One Health. And so kind of a two-part question. One, can you talk a little bit about the animal piece, like where has that come into your work at all? And then I was really fascinated by your talking about the different narcotics that you were looking for. And I wonder if you had thought at all about antibiotics as we try to understand antimicrobial pressure as a one element.
Yeah. Really important question. Yeah, those are the two great questions. I'll start with the second one. Yes, we have looked into different antibiotics, kind of hand in hand with pharmaceuticals as well, trying to see kind of what's being prescribed, what's out there. We just don't have enough data yet on the microbial part of it. Because this was just a 1-year study, and we kind of kept adding on these chemical constituents as the year went. So we have a couple data points on it, not really much to speak about, but it's possible, right? We can't do it. Should I read the first part of the question?
Oh, the animal piece.
Oh, the animal piece, yeah. One of my best friends and colleagues on our team is a veterinarian from Penn Vet, and now he actually works for CDC and FDA. And part of his goal is to build out the animal piece. So we have talked to different CAPOs throughout the country, in the Midwest, here in Arizona as well, some in Phoenix. And the drive for it is there. We haven't started the testing yet. we have conventions to start doing that. It's more about timing and ethics as well. There's a lot of ethical considerations that we have to think about. And food handling and worker safety, that kind of stuff. So we're working through those, but yeah, the animal piece is definitely being thought through.
Anybody else have any questions for the panel? Oh, sorry, go ahead.
So, question for Dr. Ryan. Buenas tardes, doctor Vargas. Le agradezco primero por su tiempo, por darnos a usted y a los investigadores. De preguntarle su experiencia en investigación en epidemiología, en este caso en infecciosis. Quería preguntarle si ha mirado algún tipo de caso donde haya secuelas inflamatorias crónicas, por ejemplo, un tipo de síndrome postinfeccioso o disfunción endótel resistente como fatiga crónica y hipertensión arterial en pacientes. Muchas gracias a ustedes.
Bien, pues muchas gracias por la pregunta. En el caso de la riqueza, habría que identificar que hay varios subtipos de la bacteria. Y la bacteria que sí se ha encontrado o que se ha identificado, claro, es un tipo de riqueza que causa la enfermedad de Lyme. Y esa está estudiada y sí causa lo que vamos a encontrar. En el caso de riqueza rickettsii, o la fiebre manchada de las montañas rocallosas, la mortalidad es tan alta, ¿verdad? O la poca identificación, que no hemos tenido oportunidad de ver un caso prospectivo. Esto quiere decir que si tenemos un caso de rickettsiosis no tratado, que se pueda presentar una defunción, no hemos podido alcanzar a investigar si va a tener algún padecimiento externo. Pero la enfermedad de Lyme sí causa artralgias constantes, llega a causar fiebres. Esta enfermedad sí está identificada porque es un subtipo de la bacteria Rickettsia rickettsii. Hemos tenido casos de pacientes que se han identificado a tiempo y no se ha podido todavía comprobar que haya un complejo que causa una inflamación crónica, un síndrome de desgaste en ellos, dado a la riqueza, ¿no? Uno de los síndromes que se había visto era en COVID. En COVID sí se encontró, sí hay identificación y en estudios, sobre todo en Inglaterra, que te hablan de después de un cuadro inflamatorio de COVID, se encontraron cardiopatías y encontramos que aumentó la tasa de incidencia de cardiopatías, principalmente en el país, gente que tuvo COVID, ¿verdad? Y era cardiópata, que desgraciadamente el COVID, por el proceso inflamatorio que produce, la reunión que los daños que produce a nivel endotelial, aumentó la probabilidad de eventos vasculares cerebrales o de arritmias fatales. Gracias.
As I see no other questions, I'd like to thank you all for your participation and also remind you that the note cards on your table will be coming around during lunch to pick them up. So if you have any questions for the president. Oh, okay. Okay. Then we have a little bit, we have a little bit longer than for lunch. So, okay, well, that's unfortunate that President Cruz Rivera will no longer be able to join us today, but we would like to inform you that we're ready for lunch, and we'd like to let you know if we want to exit through these back doors here and then enter through these side doors over here. Okay, so if you would like to start heading out to lunch, and we'll meet you back here in a bit. Thank you. Thank you all for joining us again. We're going to continue with our program. If everybody can please get settled in their seats. For the next part of our session, it's my pleasure to introduce to you Mr. Nicholas Harrison Beckett, who is the co-chair of this committee that put on this event today. He's from Arizona, Northern Arizona University, and with the Center for Health Equity and Research. And he's the co-chair for the 8th Annual ABRC Conference. So please help me welcome Mr. Beckett.
Hello, everybody, and thanks so much for coming today. Our next little assignment for you all, part of the planning process that goes into this conference is getting feedback from you all. And so you all see the laptops on your tables. There's going to be 3 questions listed on there. We would love for you to have just some dialogue, some discussion with your group, with your table, and just basically answer these 3 questions for us. And this will really help not only identify what problems you're facing currently, but also what we can do for next year's conference to maybe answer some of these questions, answer some of these problems, or even address some of these problems that you might have. And so you'll notice question number 4, when you're done with your discussions, your collaboration, you have great answers, we're going to ask that you open the Menti survey link, and we're going to have these posted on both screens over here, and basically copy and paste those answers into the Menti link. And we'll be able to see kind of like an overview of what everyone's thinking, the problems you're facing with your organization. And then we'll have another discussion at the end to kind of bring it all together. But if you have any questions, we've got a great IT team that can help out. Feel free to grab one of us. But yeah, we welcome you to the discussion, and good luck.
Thank you, Mr. Beckett. Yes. So speaking of our IT team, we have Mr. Gustavo, we have Zach in the corner over there. We've got Ivan and we've got Caesar. So please raise your hand if you need any assistance from IT, and we'll be back shortly.
All right, we have a couple more minutes on the first question before we transition to the answers of the second question. So if you have already uploaded all your answers, we're going to do it again here. And just a reminder, we only have 200 characters per response. So if you need to say it down your response, that might be the best way to do it. But yeah, please take a couple more minutes on that first question.
Okay, so now we're going to come around to each table with a microphone. And I'll ask my colleagues to help me come around with the microphones. And we're going to give everybody, pick your speaker, we're going to give you 2 to 3 minutes to briefly summarize your report. And then at the end of that, Dr. Elliot Nelson will give us the summary. Thank you.
We'll be close to
Excellent.
They're doing this stuff already.
So, mi nombre es Daniela y nuestra respuesta fue el financiamiento social y la baja participación de parte de las comunidades fueron los desafíos que encontramos.
Hi, my name is Modesto Navarrete. What we put for the first question was that there's shortage of resources for patient care, and the staff needs more treatment for patients with special needs, and there needs to be special protocols for the management of the special patients, and then there's overall shortage of care personnel.
Our top 3 challenges are funding due to continuous changes and collaboration with my people, public opinion due to misinformation or disinformation, and the wait time for specialty.
Hello, everybody. Our table, we were just discussing the 3 top challenges, and we faced, or we came to the same idea. So one of the challenges is how to educate our population, using the proper language, not only that we talk, but taking every situation like migration, education, economics, to approach them in a cultural sensitive way. and having community assessment teams with actual cultural sensitive so they can understand the community needs.
Staffing shortages, retention, and recruitment is what we discussed.
Entonces, nosotros encontramos los retos de la organización como la falta de personal, cuidadores, personal de salud calificado, y la falta de presupuesto o los recortes en el mismo. Y de igual manera, los malos hábitos y estilos de vida de las comunidades.
Bien, buenas tardes. Nosotros contestamos barreras en el acceso a la salud como discriminación, prejuicio, desconocimiento, falta de empatía y falta de conocimiento de los procedimientos.
Pues bueno, buenas tardes. Nuestro principal problema sería la desinformación, que provoca 3 retos, lo que vendría siendo la baja cobertura del esquema de vacunación, mala higiene en las calles, aumentando el riesgo de riqueza, y también aumentan los mitos de la herbolaria que hacen que no haya apego terapéutico.
Ours were pretty simple, since money, time, and equipment.
All right, everybody. Our top 3 challenges, it seemed like funding just kept coming up for us. Funding, access to it, obtaining it, keeping it, recruiting younger students and getting them involved early to work on research and health-related projects. Another issue, limited coverage of services, additional resources, recovery, transportation services, healthcare provider services. And are we answering all these questions right now? Or just the vertical? Great, you got it. Some strategies we're implementing to overcome the challenges. Applying for more grants. ADHS provides funding. In some cases, change the funding source. Look to companies, big business who have the capacity to support more. Gain trust within the communities we're working in. Changing the language of grant funding requests. Limiting problematic words, which is ridiculous, but offended. Creating partnerships like with the Yuma County Jail. What type of support does your organization need? Continuing to collaborate across institutions, kind of like what we're doing here, as well as increasing funding. And so, yeah, if anyone knows the funding, let us know. It's standable.
Okay, we had a lot of overlap, but 3 that we came up with were the projected Medicaid cuts that are coming up. Also the need for increased behavioral health services due to trauma, cost of living. And then also we talked about how to integrate AI into our medical education, public health education, and general organizational systems.
So for our first one, the 3 challenges, we talked again about funding. And then we also talked about personal resources and, for example, the library, we do partner with ABRC and youth, so we can definitely have student academic success there. Linkage and agencies to provide support for us, and also facilities and buildings for education and health services were also domains that we spoke about. Thank you.
Hi, good afternoon. So me and my team, we focus a lot on behavioral health and medical education. So for our top 3 challenges, it was lack of support, lack of knowledge, and lack of financial support. By knowledge, we are talking about, sorry, I can't read that part. It's knowledge to families who have a family member who may need support, or providing them the necessary knowledge. My colleagues over here were talking about how every behavioral health is a different type of support. And some parents and families don't know that. So providing them that knowledge of what they can do to help better, the environment around the kid is something very important. Thank you.
Buenas tardes. Nosotros concluimos que nuestros principales retos son la falta de recursos y la poca vinculación entre instituciones.
So the three challenges that we chosen, that we saw teaching is a lack of workforce training. There's not a lot of places that are here in Yuma or other cities that make it more accessible for the communities to obtain the education that they're looking for. Therefore, we have that one choice. There's also diversified, highly skilled workers that are part of more isolated areas. Due to the affordability of course programs, there's also a lack of vision for future lack of vision for the future by prioritizing things. There is not enough vision for the life and or to figure out support the changes or acceptable.
Here.
Could you please repeat that? We couldn't hear. I don't know if the microphone was on.
Oh. Hello. The top three challenges that we face, we put the options as insufficient funding, lack of the correct personnel, and no community support.
The challenges that we are the challenges that we're discussing here on our table is the lack of no health insurance. So therefore there are a lot of individuals not being able to obtain health coverage or going to the primary care physician. Also the lack of health professionals. We need more speech pathologists, counselors, doctors, and other social workers as well.
The challenges that we identified were the student/employees mental health and their well-being /burnout. The second challenge was shortage in professionals and retention. And lastly, we have the lack of collaboration between organizations. Moving forward to the written agreements.
¿Sabes? Nosotros, pues, nuestras barreras que pusimos fue barrera a accesos médicos cercanos. También pusimos que las instalaciones estaban muy lejos, falta de personal y sobre todo el financiamiento.
Good afternoon, everybody. At the discussion here on table 23, the three challenges that we have is staffing shortages and retention, especially in those positions that have high turnover rates, able to have the perfect staff that has the same vision. We have decreasing in funding, and we also have a wait list and shortage of community resources. Being in such a vulnerable population in a rural community, getting those resources to the community, we notice that might be an issue. So.
Did everybody report? So now moving on, thank you all for all those answers. And now we're going to ask Dr. Linda Elliott Nelson to come in and give us our closing remarks. But I'd like to read her bio first. Dr. Linda Elliott Nelson retired as Vice President, for learning services at Arizona Western College. She also served as Strategic Partnerships Vinculación, the Dean of Instruction, Division Chair of Modern Languages, and Professor of Spanish at Arizona Western College. Her prior work experience also involved several years in the international business sector. Dr. Elliott Nelson earned a PhD in education from Walden University, an MBA and an MA in Spanish from Arizona State University, and a BA degree from Northern Arizona University. Her activities have included co-founding the Yuma Youth Town Hall, founding and coordinating the Gifted Summer Academy for 4th through 8th graders, co-coordinating the Binational Conference on Education with Baja California, Mexico, serving on the National Modern Language Association Committee on 2-year colleges, and evaluating employee Spanish language proficiency for the city of Yuma. She was inducted into the Yuma County Educational Hall of Fame in 2024, honored with the Heart of Yuma Philanthropist of the Year in 2022 in Yuma County, and the Shirley Agnos Legacy Award for Arizona Town Hall in 2022. The Arizona Woman in Higher Education Woman of the Year in 2021, and the International Athena Leadership Award in 2019, the Outstanding University College Educator Award from the Arizona Language Association in 2000, and the Teacher of the Year from Arizona Western College in 1999. Dr. Elliott Nelson has presented internationally on community outreach, engagement, regional collaboration, partnerships, accelerated learning techniques, and community college trends. She served as the chairman of the Board of Arizona Town Hall during 2015 through 2017, President of the Arizona Historical Society Board during 23-24, Chair of the Arizona Women in Higher Education Executive Board during 2019-2020, and Co-Chair of the AZ Transfer Steering Committee and Chair of the Arizona Community Chief Academic Officers, and currently serves on the boards of the Yuma Orchestra Association, Yuma Crossing National Heritage Area, the Arizona Community Foundation of Yuma, the AHS Rio Colorado chapter, the Yuma Regional Partnership Council, First Things First, as well as the steering committee for Southwest Arizona Town Hall. Her current activities focus on community engagement, education, and development in the Arizona, California, Sonora, Baja California mega region. Please help me welcome Dr. Linda Elliott Nelson.
Thank you, Alex. At my table, Karen, Alma, Marisol, and I were solving the problems of the world. How about you? Well, in celebration of the 8th anniversary of this binational ABRC NAU Forum, we learn how much we can benefit each other by working with each other and by sharing knowledge and practice. We live in interesting times that present us with many challenges, right? And they're all happening at the same time. Funding is a huge issue, as is funding volatility. Misinformation and disinformation affect public opinion. The lack of certified healthcare workers and staffing shortages lead to more problems with wait time and the lack of accessible physicians or specialists, nurses, and more, along with community habits that affect public and private health. Barriers to access to healthcare have an impact. After COVID and given the current stressful times, we see more mental health issues. Public attitudes towards preventive care, such as vaccination, can change. Maybe because of social media influence, maybe because of what their friend or family member has told them yesterday. Not helping the situation is healthcare insurance benefits being cut. With challenges, however, we bring forward creativity and collaboration. Strategies include changing funding sources and applying for grants, along with creating and maintaining partnerships, including facilities to provide for our populations. Accurate knowledge is key to enable people to make educated decisions about their health and their family's health. Accessible ways for rural populations to access healthcare can be created, including online services and mobile services. Through working together, we can move forward. Thank you for coming today and for everybody involved in this wonderful forum. Amanda.
Thank you, Dr. Ali Nelson. With that, that concludes our program for today, and we thank all of you for coming. Gracias a todos por venir y por estar con nosotros ahora. Es el final de nuestra conferencia, pero les pedimos que las encuestas, the surveys that you've been given, to please turn them in at the bottom registration table. If you can take a minute to fill those out, and we ask you all to please drive safe, and we'll see you next year. Thank you. Oh, and we have and your certificates. Sorry, thank you. Your certificates are also downstairs for your continuing education. Thank you.